Good morning and welcome to the externally led patient-focused drug development meeting on diabetic retinal disease. I'm James Valentine and I'm joined here in the studio with Robert Levine, the founder and CEO of the Mary Tyler Moore Vision Initiative. And we're coming to you live from the Washington, D.C. metropolitan area, actually not too far from where the U.S. Food and Drug Administration's headquarters are located. It's my pleasure to turn it over to Robert, who will be providing some opening remarks. Robert?
Thank you, James. Hello, everyone. Welcome to the Voice of the Patient meeting on diabetic retinal disease, formerly called by the FDA an externally led patient-focused drug development meeting. I'm Dr. S. Robert Levine, and as James mentioned, I am the founder and CEO of the Mary Tyler Moore Vision Initiative, which is a nonprofit organization dedicated to eliminating vision loss from retinal disease due to diabetes. In all we do, we seek the insights of people personally affected by diabetes and diabetic retinal disease, like those of you participating in this important program today. Listening to the voices of patients, their families and caregivers, and how their lives are changed by fear of vision loss from diabetes and by visual impairment from diabetic retinal disease and the impacts of its treatment is essential to the ultimate delivery of better therapies and improved vision outcomes for people with diabetes. Today, I'm joining you in this important meeting not just as a clinician or a researcher, or even as a leader of a nonprofit dedicated to finding cures for vision loss from diabetes, but as someone who spent years helping the person I loved, my wife, Mary Tyler Moore, navigate her life with diabetes. I was a witness to the profound challenges that she experienced when vision loss became part of that journey. Your lived experience, what you notice in daily life, is insight that can help reshape vision research, innovation, and care. There are things only you can teach us because you are living it. Caring for someone who can no longer see the faces of the people they love, who struggle to move through spaces that once felt familiar, who worry every single day about losing even more independence, reshapes your entire world. Living with diabetes takes strength. It affects every step of daily life, and yet people keep showing up with courage and determination, like Mary did, and you all have today. Every one of you here today has a different story about your diabetes, your eye health concerns, and threats to your vision. But today we are united by a powerful shared goal, ending vision loss due to diabetes as soon as possible. I am, and we all are, grateful for your participation and willingness to share your stories. I want to offer a special welcome to the many staff members of the U.S. Food and Drug Administration that are taking the time to be with us today. Thank you for giving us permission to hold this meeting. We're excited to have you with us and hope that you will learn a lot today from our community of patients and caregivers affected by diabetes and vision loss due to diabetic retinal disease. I'd like to thank Boehringer Ingelheim, Genentech, and Regeneron for their leadership in sponsoring today's meetings, as well as the many nonprofit and academic institutions who've helped make today possible. Along with representatives from our pharmaceutical company sponsors, all of whom very much want to hear your stories and learn from you, we are pleased to have in attendance representatives from diabetes research advocacy and professional organizations, clinical and research centers from around the globe, and importantly, the U.S. Food and Drug Administration, who highly value the voice of the patient as a guide to their decision-making on new drug approvals. Thank you for joining us today. And once again, I want to welcome the members of our community of people with diabetes, both type 1 and type 2, who live with vision loss or fear of it from diabetic retinopathy, diabetic macular edema, diabetic retinal neurodegeneration, and diabetes-related retinal and vitreous hemorrhage and retinal detachment, what we as a group call diabetic retinal disease, or DRD. Today's meeting is the result of many months of planning and people working together behind the scenes. I want to extend my deep gratitude to everyone who has had a hand in preparing for this meeting, especially Dr. Latrice Faulkner and Jocelyn Clancy, who work with me at the Mary Tyler Moore Vision Initiative. We are grateful to have this opportunity to ensure that patient and caregivers' perspectives are considered in the drug development and regulatory processes. Diabetic retinal disease has a profound and far-reaching impact on all who live with diabetes and their caregivers. It not only threatens vision and in severe cases causes blindness, but also affects nearly every aspect of daily life. Sight shapes how we connect with the world, share in family moments, pursue careers, and experience independence. The gradual loss of vision can be overwhelming, leading to anxiety, loss of self-confidence, and even social isolation. Tasks that once required no thought, reading, driving, or recognizing loved ones, may become difficult, unsafe, or even impossible. The emotional toll is significant, as individuals may feel grief for the loss of treasured experiences, frustration with daily challenges, and concern about an uncertain future. Caregivers are deeply impacted as well, facing the demands of assisting with transportation, medication management, and adapting living spaces for safety. Their support is invaluable, but can be physically and emotionally taxing, often carried out with limited resources. Treatments for DRD have evolved, but remain imperfect. While advances offer hope in preserving vision and slowing disease progression, the underlying causes, complex changes within the retina, are still not fully understood. Most of today's treatments are for late-stage disease, when vision is acutely threatened or already lost, rather than being focused on preventing or reversing vision loss, leaving many patients and caregivers wanting for more effective solutions. Today, as researchers, clinicians, patients, and industry leaders join together, we are reminded that vision is something many of us take for granted until we are at risk of losing it. Our shared goal is to foster innovation and advance treatments that respond to the concerns of people living with diabetes and their caregivers, to eliminate vision loss from diabetes and preserve people's independence and the simple joys that vision brings, like driving a car, seeing a loved one smile, or reading a favorite book. I want to express my appreciation to the academic and industry investigators who've dedicated their careers to seeking new preventive strategies and cures for people living with diabetes and diabetic retinal disease, and who are moving us closer to new treatments and ultimately a world without vision loss from diabetes. Our hope is that this meeting will encourage future research and use the voice of the patient as a guide to the development of new treatment options for people with and at risk for vision loss from DRD. To our diabetes community, we invite you and your loved ones to call in or submit comments during the program. We also ask that you stay with us throughout the day as you are able and participate in remote polling. We want to hear as many perspectives as possible, and we'll do our best to get to as many calls and comments as we can. When participating, please only use your first name, city, and state or country. No other identifying information needs to be shared. Be assured that any comments offered that we are unable to share in this live session are still very important and will be included in the Voice of the Patient report, a formal summary of this important meeting that will be presented to the FDA and drug companies for their consideration when making decisions about new drug development and regulatory approvals. If you have to drop off or we are unable to get to your question, please know that your voice is still valued. Please go to our website at www.marytylermoore.org and click the Share Your Comments button to provide your experiences, concerns, and hopes in writing. Your comments will still help shape the formal Voice of the Patient report. To kick off today's meeting, I'm pleased to introduce our distinguished speaker from the U.S. Food and Drug Administration, Dr. William Boyd. Dr. Boyd serves as the Director of the Division of Ophthalmology within the Center for Drug Evaluation and Research at the FDA. Dr. Boyd will be providing us with some opening comments from the FDA perspective and how the voice of the patient is critical in developing new treatments for DRD. Dr. Boyd, thank you for joining us.
Thank you for that kind introduction. My name is William Boyd, and I'm happy there's so many patients, caregivers, and advocates involved in today's meeting. Thank you all for being part of this discussion and sharing your experiences with us. I would also like to thank the Mary Tyler Moore Vision Initiative and all of the staff that were involved in planning this meeting. I know we have representation from industry, academia, and other medical product development stakeholders with us today. While the FDA plays a critical role in medical product development, we are just one part of the process, and I'm glad to see a high level of interest from those of you who also play important roles. In January 2024, Dr. Wiley Chambers retired from the FDA after a career of greater than 30 years. I'm also an ophthalmologist at the FDA, and I joined in 1998 under Dr. Chambers, and I'm currently lead the Division of Ophthalmology. Currently available treatments for diabetic retinopathy and diabetic macular edema have benefits and can reduce long-term disease-related complications. But these treatments do have limitations and potential risks. Anti-VEGF, vascular endothelial growth factor therapy, uses medications injected into the eye to block the VEGF protein. These are not self-administered, and they require administration by trained personnel to avoid potential eye damage and risk of infection. We recognize that there is more progress to be made and more work to be done to further advance the treatment and management of diabetic eye disease. These types of externally led, patient-focused drug development programs give the FDA and other key stakeholders, including medical product developers, healthcare providers, and federal partners, an important opportunity to hear directly from patients, their families, caregivers, and patient advocates about the symptoms that matter most to them, the impact the disease has on patients' daily lives, and patients' experiences with currently available treatments. We would like to hear what specific things patients look for in an ideal treatment to manage their condition. This will help inform the focus of new drug development and future clinical trials. The FDA protects and promotes public health by evaluating the safety, effectiveness, and quality of new products, but we do not directly develop medical products or conduct clinical trials. It is, however, the FDA's responsibility to ensure that the benefits of a product outweigh its risks. Having this kind of dialogue is extremely valuable for us because hearing what patients care about can help us lead the way in figuring out how to best facilitate medical product development for diabetic eye disease and understand how patients view the benefits and risks of therapies and devices for diabetes. We look forward to incorporating what we learned today into the agency's thinking and understanding of how patients view benefits and risks of therapies and devices for diabetic eye disease. Your input and perspectives really help us and will also help industry and academia to move the drug development process forward to ensure that new medications meet the needs of people living with diabetes. Once again, we're all here today to hear the voice of the patient, so thank you for your participation. We are grateful to each of you for being here and sharing your personal stories, experiences, and perspectives. Thank you, and I'll now send it back to the studio.
Thank you, Dr. Boyd. Next up, Dr. Jennifer Sun will provide a clinical overview of diabetic retinal disease. This will serve as a scientific foundation for today's discussion. Dr. Sun is a professor of ophthalmology and surgery at Harvard Medical School. Since 2005, she has served as chief of the Center for Clinical Eye Research and Trials of the Beetham Eye Institute at the Joslin Diabetes Center. Dr. Sun is also chair for diabetes initiatives of the DRCR Retina Network, a National Institutes of Health-sponsored collaborative of retina sites performing clinical research in diabetic eye disease and other retinal disorders. In addition, she serves as scientific co-director for the Mary Tyler Moore Vision Initiative and has led nationwide studies focused on breakthrough treatments and evaluation methods for diabetic eye disease. Dr. Sun, I will now turn this over to you.
Thank you so much for that really kind introduction. It is a pleasure to be here today at this really important meeting, and we really look forward to hearing all the patient voices and understanding how your voices can further inform future drug development. Here are my financial disclosures. There is no doubt a growing worldwide epidemic of diabetes. Today, the International Diabetes Federation estimates that there are approximately 589 million adults ages 20 to 79 years old who are living with diabetes worldwide, and that's 1 in 9 people. And those estimates of the global rates of diabetes in that age group have climbed substantially since the year 2000, when it was estimated that only 151 million patients were living worldwide with diabetes. Unfortunately, over the next few decades, we expect a 45% increase in that number of people living with diabetes, and the total number of adults is predicted to rise to 853 million by the year 2050, or 1 in 8 people worldwide. When we think about diabetic retinopathy in the United States, the prevalence, the rate of diabetic retinopathy has more than doubled in people aged 40 years and older that live with the disease from 2004 to 2021. Today, it's thought that 9.6 million people in the U.S. have diabetic retinopathy, more than a quarter of those with diabetes. And when you look at young people, ages 0 to 24 years, more than 1 in 10 people is estimated to have diabetic retinopathy that have diabetes. So this is a disease that's really affecting our young people. In total, we think that 1.84 million people have vision-threatening diabetic retinopathy. So what do we know about diabetic retinopathy? Well, older studies, like the Wisconsin epidemiology study of diabetic retinopathy, have estimated that if you live long enough with diabetes, say about 15 years or so, over 90% of people will have some level of retinopathy in their eyes that's clinically visible. And if you live with 30 years or more of diabetes, about 60% or more will have the most advanced form of the disease or proliferative diabetic retinopathy. Diabetes starts with chronic hyperglycemia or elevated levels of blood sugars. And those can contribute to multiple abnormalities in molecular pathways throughout the body, including the eye. And these include advanced glycation end product accumulation, polyol pathway activation, protein kinase C activation, hexosamine activation, and renin-angiotensin-aldosterone system abnormalities. Those molecular pathways lead to a host of cascading factors that include activation of cells like astrocytes, microglia, and Mueller cells in the retina, oxidative stress pathways, loss of specific types of cells such as endothelial cells and parasites that support and line the blood vessels, and inflammatory cytokines that can cause vascular damage and ultimately retinal ischemia. All of these changes are both involved in looping feedback pathways and are upregulated in ways that cause retinal neuronal dysfunction and abnormalities in the retinal vasculature that ultimately lead to the clinical disease that we call diabetic retinopathy. I'll highlight some specific selective loss of retinal parasites as a very early and hallmark sign of diabetes when we think about the pathophysiology of diabetic retinopathy. And here in this picture of a normal eye, you see these little round dark nuclei pictured here and here. And in a diabetic eye, we lose many of those. The black arrows show you areas where there are ghost cells, loss of nuclei, although you can still see their shadow. And what happens in many of those areas is we start to have abnormalities of the retinal vessels and the retinal capillaries, with the formation of things like microaneurysms or abnormal outpouchings of the capillaries that form in these areas of parasite loss and acellular capillaries. Microaneurysms and other lesions are classically known to create the entity that we call diabetic retinopathy. And here are some of those classic lesions. On this panel, we see in the black circles, little areas of red dots and blots that represent small areas of bleeding in the retina, or again, those microaneurysms, abnormalities of the retinal capillaries. We can also see intraretinal microvascular abnormalities, which are shown here and which represent areas where the retinal blood vessels lose their normal, smooth, branching architecture and sort of move in tortuous ways and can leak fluid and cause visual disturbances. Areas of venous beading or vascular caliber changes are represented by alternating areas of constriction and dilation in the retinal vessels, as shown here. And finally, in the most advanced forms of diabetic retinopathy, we get areas of new vessels growing or neovascularization, sometimes on the optic disc, as shown on the left, and sometimes elsewhere in the retina, as shown on the right. All of these lesions are graded in photographs that we use to establish overall level of diabetic retinopathy severity. And they wrap up into a scale that was developed in and validated in the early treatment diabetic retinopathy study that we call the ETDRS DRSS. And that's shown here. And these usually progress through levels of absent or no DR, through severity levels of mild, moderate, and severe non-proliferative disease, and then into most advanced forms of diabetic retinopathy, proliferative diabetic retinopathy, again, where new blood vessels grow and form in the retina and can cause vision-threatening complications. At any level of diabetic retinopathy, we can see the development of diabetic macular edema. I'll show you pictures of that in a moment, but this represents central swelling of the retina and can be visually important. So why is it important that we stage diabetic retinopathy? Well, one reason is that more severe levels of retinopathy are more likely to lead to vision loss. But also, studies have told us that current diabetic retinopathy severity is one of the best predictors of who's going to have future worsening of their diabetic retinopathy. In these bar graphs, you can see that people with mild non-proliferative disease, shown in the green, have much lower rates of progression or worsening of retinopathy than do people with more severe levels of retinopathy, such as severe NPDR. All of this new information that we have has also really highlighted the fact that diabetic retinal disease affects the entire retina. We go through the entire depths of the retina, which is a very highly structured tissue with multiple layers, as shown here in the schematic. And with the onset of diabetes, there's a number of abnormalities that can occur across the retina and again through the retinal layers. And this has given rise to a new term. Classically, we've talked about diabetic retinopathy as referring to the clinically visible, mostly vascular changes in the retina that are documented on photographs of the central 30 degrees. In contrast, our use of the word diabetic retinal disease, or the phrase diabetic retinal disease, really includes all retinal abnormalities that occur from the time of diabetes onset or diagnosis that are present across the depth and across the breadth of the retina. And so there's been a move to start to update and replace our classic ETDRS diabetic retinopathy severity scale shown here with more holistic and multidimensional imaginings of what happens at the time of diabetes onset, including not just retinal vascular function, but also taking into account what happens in terms of worsening neural function within the biochemical milieu of the retina, the context of the patient's overall systemic health, and how those relate to patients' visual function and quality of life. Let me show you just some representative pictures of different stages of diabetic retinopathy so you have an idea of that. Here's a normal retina. We see here the optic nerve shown here, along with that central dark spot that includes the central most visually important retina, and then those red lines that represent the retinal blood vessels arching out from the optic nerve surrounding that central retinal macula area. A retina with mild non-proliferative disease starts to develop some faint and sometimes difficult to see, but present, usually red dots and blots that represent hemorrhages or microaneurysms. Over time, those can increase in severity and extent. And retinas with proliferative retinopathy, the most advanced form, start to show new vessels growing across and within the retina. And those can lead to areas of bleeding, as well as scar tissue. In the most advanced stages, proliferative diabetic retinopathy can lead to traction retinal detachments, as scar tissue shown here spreads across the retina and tugs on the retina, detaching it from the back of the eye. This is a stage at which there's high risk for severe vision loss if it's not treated in a timely manner. In addition, another vision-threatening complication of diabetic retinopathy is diabetic macular edema. Here, the color map shows a central area of retinal swelling in the white and red, and the retinal cross-section next to it shows that hill of retinal swelling with intraretinal cystic changes. Diabetic macular edema, as we said, is swelling of the central visually important retina that results from abnormal vascular permeability. And it's the most common cause of moderate vision loss in our patients with diabetes, particularly in developed countries. There are many symptoms of diabetic retinal disease, and these include decreases in visual acuity in the central vision, flashing lights, floaters, decreased color vision, changes in contrast sensitivity, and reductions in peripheral vision. And these symptoms can develop whether you have type 1 or type 2 diabetes. They're not different between those diabetes types. And yet, a really important thing to note is that vision-threatening diabetic retinal disease can be present with no visual symptoms whatsoever. That's important because we need to make sure patients understand that and that they're getting to have their annual dilated eye examinations, regardless of whether or not they notice changes in their vision, so that we can catch diabetic retinal disease before it becomes visually significant and treat it as needed. The recommended eye examinations for patients with diabetes and no retinopathy by the American Academy of Ophthalmology is for type 1 patients 5 years after diagnosis and then on a yearly basis thereafter. For patients with type 2 diabetes, we want them to be seen at the time of diagnosis and again yearly thereafter. And patients who are diabetic and pregnant, they should be seen soon after conception and usually at least once every trimester. A few notes to this: abnormal findings will dictate more frequent follow-ups. So there are some patients who develop diabetic retinopathy or diabetic macular edema that we're seeing as frequently as every month. Patients who are just going through puberty also require increased vigilance because there's an increased risk of progression at that time. And women who develop gestational diabetes don't actually require eye examinations during pregnancy. Control of systemic risk factors results in improvements in retinopathy outcomes. Blood sugar control is the hallmark and the foundation of our treatment for diabetic retinopathy, and we know from past studies that every percentage point decrease in hemoglobin A1C, a measure of 3-month average blood sugar control, leads to a 37% decrease in risk of microvascular complications. Improvements in blood pressure can lead to a 34% reduction in retinopathy worsening or progression, and a 47% reduced risk of vision loss of 3 lines or more. Higher cholesterol levels are associated with lipid deposits in the retina and decreased vision, so it's also important to control cholesterol. Unfortunately, only 60% of people with diabetes have the recommended yearly screenings for diabetic retinopathy in the US. And moreover, we find that many patients who have vision-threatening retinopathy on documented fundus photographs are unaware that they have any retinopathy, even when they've had an eye examination within the last year. A Joslin Diabetes Center study looking at tens of thousands of patients in their telemedicine program showed that nearly 55% of patients with vision-threatening retinopathy did not know that they had any disease in their eyes at all. Given these challenges, how do we deal with the global burden of screening for diabetic retinal disease? Well, there are promises with our improvements and advances in technology, including artificial intelligence algorithms. To date, there are 4 AI systems that have been cleared by the U.S. Food and Drug Administration for retinopathy screening, including the Digital Diagnostics Luminetics Core, the iNav iArt system, the AI Health AIDS, and the Retina AI Discovery Platform. I'll sum up by saying that for diabetic retinal disease, we know that the worsening global epidemic of diabetes will put substantially more people at risk for vision loss from DRD over the next few decades. The current classification system for diabetic retinopathy helps to predict who is at risk for worsening eye disease, but has important limitations and needs to be updated. There are very promising recent advances in retinal imaging, assessment of visual function, and artificial intelligence methods to rapidly identify patients who need referral for eye care. But much work remains to be done to create a world without vision loss from diabetes. Patient voices are needed to help guide evaluation of potential new preventions, therapies, and approaches for diabetic retinal disease. And so I really look forward to hearing the discussion today and the valuable input that your voices will provide to this concept and to these issues. I really look forward to the rest of the discussion and hearing all of your voices today. I will say thank you at this point and hand it back to the studio.
Thank you, Dr. Sun. I'd now like to welcome our moderator for today's meeting, James Valentine. James has worked for the past 18 years as a champion for the patient voice as part of the regulatory process. He previously worked at the FDA, where he was a patient liaison, helping to incorporate the patient voice into medical product review across the FDA's various medical product center and review divisions. There, James helped develop and launch the Patient-Focused Drug Development Initiative. In private practice of law, James has worked with many organizations to ensure their community's voices are heard by decision makers. He has also been involved in helping plan and moderate many of the over 75 externally led PFDD meetings, including this one, so we are in good hands with James. James, I'll let you take it over from here.
Well, thank you for that introduction, Robert, and it's such a pleasure to be here this morning with this community as we explore your experiences with diabetes and living with vision loss and being at risk for vision loss as a result of diabetic retinal disease. So now that we've heard a clinical overview from a disease expert, we get to do that. We get to turn to the core of this morning's meeting, which again is to hear from you, people with diabetes who are living with or at risk of vision loss from diabetic retinal disease, as well as your direct family members, caregivers, and others that have lived with you and gone through experiences with you. Patient-focused drug development is a more systematic way of gathering patient perspectives on their condition and on available treatments. As you heard from FDA's Dr. Boyd, your input can help inform the agency's understanding of diabetic retinal disease to inform drug development and review. This morning's meeting is interactive, so let me tell you a little bit of what we'll be asking of you and how today's meeting will be organized. So today is structured into two overarching sessions. In our first session this morning, we'll be exploring the patient and caregiver experience of living with and being at risk of vision loss as a result of diabetic retinal disease, and how those different symptoms and health effects and concerns impact your daily lives. In the afternoon, we'll come back together and build on that discussion as we explore your experiences with treatments and strategies to try to help manage and prevent diabetic retinal disease symptoms. So what will these two discussions look like? We'll be using a few different methods to bring your voices into the discussions. We'll kick off each of our two discussions first by hearing from panels of patients and caregivers of individuals living with and at risk for diabetic retinal disease. This will help set a good foundation for our discussion. And those individuals on the panels were selected to reflect a range of experiences with this condition. However, we know that no single panels can reflect the full range of experiences, which is why we'll then broaden the discussion to all of you in our live audience through a facilitated discussion for all of our patients and caregivers in the audience. We'll be asking that you build on those panel discussions. I'll be asking questions and inviting you to call in and write in, share your name and offer a comment. And we'll be giving you instructions on how to call in and write in as we get to that part in our first discussion this morning. We'll also be broadening our discussions through the use of polling questions. And we ask that patients and caregivers only respond to these questions, and you can do so using your phones or using a new browser tab on your computer you're following along today. And in fact, we want to get you into that system now, because as we go to different polling questions throughout the day, you'll be able to just keep that web page up. So if you scroll down on the live web page you're following along today, you'll see a link, or you can type this in yourself into your phone or in a new tab on your browser. You can type in www.pollev.com/DRD PFDD. Again, that's pollev.com/DRD PFDD. Once you get to that web page, you just keep that open, and we'll be getting to our first set of polling questions very soon. These questions are going to help us get a sense of the broad experiences of our audience and help aid in our discussion. There will also be an opportunity to provide written comments, whether you're participating live today and weren't able to share all of the comments that you would like to share live, or if you're watching this on demand after the live meeting, know that you too can submit your written comments for 30 days after today's meeting using the form on the web page that's there today. All of today's input plus all of that written input will be summarized in the Voice of the Patient report, which will be provided to the FDA, as well as be made available online for researchers and drug developers. One last thing before we get into our first set of polling questions, I want to cover a few ground rules for today as we get into this discussion. We encourage people living with diabetes who either are experiencing vision loss for diabetic retinal disease or who are at risk of vision loss, as well as their family members, close friends, and other direct caregivers to contribute to the dialogue. Again, we'll be asking you to do this through polling, calling in by phone, and submitting written comments. The discussion today is limited to patients and direct caregivers. However, we do welcome and have attending colleagues from the FDA, drug developers, and clinicians who are here to listen. I also want to note that views today expressed today are inherently personal, and the discussion may get emotional at times. So respect for one another is paramount, and to that end, we ask that you try to be focused and concise in your comments, so that way we can hear as many voices as possible. So without further ado, let's get into our first set of polling questions. Again, this is for patients and care partners only. You can go to that webpage, www.pollev.com/DRD PFDD. That's pollev.com/DRD PFDD. And once you get there, you'll see our first question for today, which is we'd like to know, are you A, someone with type 1 diabetes at risk of or living with vision loss from type 1 diabetes? Are you B, someone with type 2 diabetes that's at risk or living with vision loss from type 2 diabetes? C, a family member, or close friend, or other direct care partner of someone with type 1 diabetes that's at risk for or living with vision loss from type 1 diabetes? Or finally, D, a family member or close friend of someone or other direct care partner of someone living with type 2 diabetes at risk for or living with vision loss from type 2 diabetes. Note that for everyone responding, there's no submit button that you need to press. You can just click on your selection and it will automatically be logged. And as we can see for the live audience today, we can see those results coming in as you make those selections. We're going to, even though this is an easy question to answer, we'll give everyone just an extra couple of moments to make sure that we get our everyone a chance to get into the polling system. So that way, once you're there, you'll be able to stay with us as we advance through different questions here, both throughout this morning as well as in the afternoon.
And do please remember that your responses are anonymous, so we don't track who is responding in what way.
So as it stands, it looks like about half of our audience are people with type 1 diabetes who are either at risk of or living with vision loss as a result of their condition. However, we see good representation across each of these different patient and caregiver categories. We have about a little over 10% of our audience are those living with type 2 diabetes. Then we see from our care partners about a quarter of our audience are representing those with type 1 diabetes that are, again, at risk for or living with vision loss. And then finally, about 10% of those are our care partners for those living with type 2 diabetes. So whichever of these four categories you represent, we want to hear your voices throughout today's program. So we encourage you to call and write in later in the program. With that, we'll go ahead and move to our next polling question. So here we'd like to know, where do you currently reside? And the options here are A, U.S. Pacific Time, B, U.S. Mountain Time, C, U.S. Central Time, D, U.S. Eastern Time, E, U.S. Alaska Time, F, U.S. Hawaii Time, G, Europe and UK, H, the Middle East, I, Asia, J, Canada, Canada, K, Mexico, Central America, South America, or the Caribbean, or L, some other country or region not listed in the other response options. So we'll give everyone a few moments here to let us know where you currently reside. This is for our patients and our caregivers. Not surprising for a meeting starting in the morning on Eastern time. We're seeing a majority of people logging in here, but we do see representation from across all of the major U.S. time zones, and so expect those numbers to grow as the meeting progresses a little bit today. But
and James, we do have comments that have come in advance from the UK and elsewhere in Europe.
Absolutely. So no matter where you live within the United States or around the world, we encourage you to have your voice heard today as well. We'll go to our next polling question. So here we are asking, what is your gender for those who are living with diabetes, or for our care partners, the gender of your loved one with diabetes who's either at risk or living with vision loss. And the options are A, female, B, male, C, non-binary, or D, if you prefer not to say. Again, these morning questions just to get a sense of our audience here today. These polling questions will get more challenging and more thought-provoking as the day goes on, I promise. But thank you for helping us get a sense of our audience here today. So as it stands, we have about 2/3 of our audience are representing individuals with diabetes who are female, and about 1/3 of our audience representing individuals with diabetes who are male. No one reporting non-binary or preferring not to say. We'll go to our next polling question. So here we'd like to know, what is your or your loved one's annual family or household income before taxes? We understand that conditions like diabetes and diabetic retinal disease can provide financial demands on a family. And so we'd like to get a sense of our audience's socioeconomic representation. And so the options here are A, less than $25,000, B, $25,000 to $50,000, C, $50,000 to $75,000, D, $75,000 to $100,000, E, $100,000 to $150,000, F, $150,000 to $200,000, or G, $200,000 or more, or H, if you prefer not to say.
And thank you all for answering this question. We know it's sensitive, and we appreciate it.
Absolutely. And importantly here, seeing representation across every different of these income brackets that we're seeing. Again, recognizing that the complex nature of living with a complex disease like diabetes and the financial impacts. Go to our next polling question. So here we'd like to know, for those living with diabetes, how old are you? Or for our care partners, the age of your loved one living with diabetes, or the age for those who loved ones who have are care partners for those who have passed away, the age at which your loved one passed away. The options are A, less than 18 years of age, B, 18 to 24 years of age, C, 25 to 34 years of age, D, 35 to 44 years of age, E, 45 to 54 years, F, 55 to 64 years, G, 65 to 74 years, or H, if 75 years of age or older.
Yeah, and it's a really good representation in terms of age distribution. And just a reminder that diabetes, type 1 and type 2, is a leading cause of vision loss and blindness globally in working age adults, and it's reflected in the distribution of the ages that are participating today.
Yeah, we're seeing almost a perfect bell curve distribution here, with the greatest group represented being that 45 to 50 year age range, followed by 34 to 44, and the 55 to 64, but participation, including those representing those people less than 8 years of age, is all the way up through those greater than 75 years of age or older. So one more polling question here this morning, again, to get a sense of our audience. So here we want to know, at what age were you or your loved one diagnosed with vision loss from diabetes? And the options here are A, less than 18 years of age, B, 18 to 30 years of age, C, 31 to 50 years of age, D, 51 years of age or older, E, if you're not sure, don't remember, or F, if you or your loved one do not yet suffer from vision loss from diabetes. So you do not yet have a diagnosis of vision loss. So that's for our at-risk population here today. So we're already seeing that shift a bit here from the current age, and giving a sense that we've have a number of people who may have been living with this diagnosis, as we see about a third of our audience being diagnosed between 31 to 50 years of age, about 20% in that 18 to 30 year age range, and about 10% prior to age 18. No one reporting that their vision loss onset at age 51 or older, a few that are unsure, and then about 40% of our audience who are at risk. And we can't emphasize enough how important it is to also hear from that group of individuals today to understand, even though you have not yet experienced vision loss, your worries and concerns and how those impact your daily lives. And in the afternoon, we'll be focused on what you might be doing to try to help prevent vision loss.
And again, it's a reminder that vision loss from diabetes occurs in the prime of people's working and family building lives.
So thank you, everyone, for participating in these first batch of polling questions. Again, you can keep those polling question webpage open, and as we go to them later in the program, you will be able to just automatically see them pop up there and answer those questions. But now we get to transition to our first session of the day, which is all about diabetic retinal disease symptoms and daily impacts. You're seeing here a list of some of the questions that we want you to help answer. So we want to explore the different symptoms and health effects of vision loss from DRD, and want to know which one to three of those symptoms have had the most significant impact on you or your loved one's life. We want to know, how does vision loss or the fear of vision loss from DRD affect you and your loved one on best days and worst days, knowing that there may be some day-to-day variability in how you experience this condition. We also want to know, how have your symptoms changed over time, whether that's over the course of weeks, months, or even many years, and how has the ability to cope with those symptoms changed over time. We also want to know not just about those direct symptoms and health effects, but the impacts on your lives. So are there specific activities that are important to you or your loved one that you or they can't do either at all or as fully because of vision loss from DRD? And finally, recognizing that even for those of you who already experience vision loss, and certainly for those of you at risk, that you have fears. And so what do you fear the most as you or your loved one gets older? What worries you the most about you or your loved one's condition? So to get us started on this topic, it's my pleasure to introduce our first panel, some of your peers, patients, and caregivers who will be helping weigh in on these topics. We have Anne-Marie, Jessica, Chelsea, Arthur, and Nina. Anne-Marie, take it away.
Hi, my name is Anne-Marie. I'm a 61-year-old American. I'd like to share glimpses into my life and the dark side of diabetic retinal disease. I was diagnosed with diabetes at the age of 3. At 7, I attended a 2-week intensive diabetes educational conference to learn how to manage diabetes. Urinalysis was the testing du jour. It provided hours-old information that wasn't beneficial for diabetes management. Lack of diabetes research supported the pretense that this was a successful treatment scaffolding. Sadly, that scaffolding only supported a noose on good health for decades. The conference stressed diabetes disease complications and their prevention. They presented grim forecasts. You will become blind. Very vivid pictures accompanied the lectures, providing effective scare tactics for a 7-year-old. I decided that 2 diseases were the worst: gangrene and eye disease. Gangrene horrified me. Black, decaying toes. But for me, going blind was worse. They said retinopathy surgery involved removing the eyeball from its socket. An incision in the eyeball gave access to repair it. As a 7-year-old, the surgery became a horror fantasy. The surgeon tries to suck my eyeball out, but it doesn't cooperate. Then, suddenly, pop, out comes the eyeball. If I could choose which body part to keep, it would be my eyes. With eyesight, I could see glucose results. I could see dosing the syringe, and I could assess early fissure detection in my feet. At 7 years old, I saw eyesight as the front line in the battle for better health. One day in 4th grade reading class, I was chosen to read aloud, but every other word disappeared from the page. I squinched my eyes. I brought my eyes close to the page and away. Could blindness be so sudden? My teacher knew something was wrong and asked if I needed sugar. I wondered, does sugar cure blindness? After eating sugar cubes, ecstatically, my vision came back. My entire life, I feared going to sleep at night. Hypoglycemia frequently crept into bed with me. Convulsions quaked my body. Every night, I wondered if this would be the night the hypo monsters got me. Only luck supported me because there were no new diabetes tools. At the age of 25, a background retinopathy diagnosis sunk my heart. Luckily, no surgery was necessary, but the diagnosis created dread. Blindness would eliminate my autonomy in diabetes, and not to mention destroying all the pleasures of sight. Slowly, type 1 diabetes research advanced. One excellent April day, Sir CGM and Lady Deglutic galloped into my life. They quickly slayed the severe hypo monsters, transforming my life. The metamorphosis catapulted me to a healthier future. It was almost a feeling of freedom. My whole life, every medical support team said, maintain good glucose numbers for better diabetes health. This puts the onus exclusively on me. But in reality, I need modern medicine to maintain eyesight. The fact is, People are only as good as the medicines and technology available. Dealing with type 1 diabetes makes Sisyphus look like he's lounging at the beach. He's free from the weight of losing eyesight due to DRD. My vision is clear now. My future is hazy. I am plagued with the incurable haunting of losing my eyesight and then losing autonomy. Blindness opens the door to hypo and gangrene monsters. Who will step forward to help me check my blood glucose and the imperative arrows 80 times a day? Who will help with 13 injections a day? I've trudged through the dark ages of no new diabetes tools. Now I taste the sweetness of progress with CGMs. DRD research would forge a healthier future. It would elate me to manage my diabetes myself and watch Mary Tyler Moore reruns. I could stop asking myself, how will you make it on your own? With DRD developments, I could say to myself, I just might make it after all. I was 17 years old and alone at my annual eye exam when the doctor told me I had mild retinopathy. Thanks to advances in science and careful management of my diabetes, my vision has been preserved far longer than I've expected or even hoped for. The only thing keeping my vision intact is my discipline and daily vigilance over my blood sugars. And that might not be enough. There's this constant fear that despite doing everything right, vision loss can still happen. Every meal, every conversation, every decision carries the quiet question of, what if it's today? What if my vision changes today? It wasn't until my early 30s I began noticing changes. Floaters appeared as thin, black, amoeba-shaped strands drifting across my line of vision and impossible to ignore. I would see these several times a week. Flashes of light came later, and in bright settings. They would momentarily blind me, like a flashbulb in your eyes. And these flashes were isolated a couple times a year. They only lasted seconds, and they were so terrifying, it would convince me that I was going blind right there and then. One time I was on a ski slope with no idea how I was going to get down the mountain. On my best days, I can read without straining, I can manage complex CMC tech transfers without distraction, and I can walk outside without feeling like the light is playing tricks on me. And these days are amazing. They let me forget how fragile my eyes really are. My symptoms have progressed from mild non-proliferative retinopathy to include early cataract and astigmatism. I live with the expectation that my eyes will deteriorate. My worst days, like on rainy nights, snowy nights, are the ones where the environment exposes every limitation. Darkness, rain, glare can blur everything and make simple decisions more exhausting. Everyday scenarios like walking my dog at night or navigating a dimly lit restaurant feel tense. They're stressful. And I no longer react instinctively. I am scanning, anticipating, and adjusting before anything can go wrong because I just don't trust my vision anymore. And now everyday decisions require this constant calculation. Will this make my symptoms worse? Will I be safe? Will I affect others? And the only thing I can do is manage my blood sugars and wait for my eyes to get worse. Living in this in-between space is its own misery. I don't want to wait for my vision to get worse. I want to address these issues right now before they get worse. I don't want to wait, especially since many changes go unnoticed. There's this disconnect between what's happening in my eyes and what I perceive. My annual eye exam reveals whether my world is shrinking or not. If my vision seems normal to me, and the tests tell another story. And that gap between perception and reality is unsettling, to say the least. I just stress out before every one of these appointments, convinced that this is the one I'm going to find out I'm going blind. And this affects more than just me. In the weeks before my appointment, fear consumes me and anxiety spills over to my family. And it's just not my anxiety. I do things like limit driving at night, which shifts responsibilities onto my husband, picking our daughter up from practice, getting us to events, running errands. These change has created such stress and tension. We don't need this. I miss the independence that I once took for granted and the spontaneity that used to be part of my daily life. If I could regain one thing, it would be the ease and confidence I once had navigating evenings and nighttime routines. That's the loss that touches nearly every part of my family's life, and it magnifies my vulnerability. Looking ahead, I worry about the unpredictability of progression and how ridiculously few tools I have to recognize, slow, or stop it. I think about future celebrations and ordinary moments that make life meaningful. Watching my daughter win her event at a big swim meet, visiting the family lake house, and watching the sunrise with that same appreciation my grandparents had. To the faces of possible grandchildren that I may never see. The idea that my vision might fade during these years is devastating.
My name is Chelsea. I currently reside in Pensacola, Florida. I was diagnosed as type 1 diabetic around the year 1988-89 when I was 25 years old. Around 2005 is when I started to experience blood leaks in my left eye, which turned into me having to get surgery, a vitrectomy to remove the blood from my eye and to bring my vision back. After I've gotten my first surgery in my left eye, soon after I started getting blood leaks in my right eye. And I had the same vitrectomy surgery in my right eye. Unfortunately, due to the retina being detached, I was unable to get much of my vision back in my right eye. So currently now I have about maybe 5% vision in my right eye. And it's been like that ever since. What they had to do was basically fill my eye with a silicone gel to hold the retina in place. So that was in itself a hard pill to swallow, that I would never get my vision back in my right eye, which opened up a slew of challenges. I lost my night vision, so I'm not able to drive at night. I'm able to work, but I need accommodations at work. I need to have myself positioned in a certain way where I can have enough light to see, to have my monitors placed in a certain way so I can see and be able to operate. Thus, having to rely on FMLA whenever I should have a problem with being able to see, because I eventually developed an issue with my left eye, to which sometimes when I wake up in the morning, my eye will be extremely dry and I open my eye and it will scratch my cornea. Thus, no vision in the right eye, then very blurred vision in my left eye to where I can't drive or operate the computer for my job. Years ago, most of my struggles were just mostly depression and anxiety, having to live with not knowing whether I'd ever get my vision back or whether I'd lose vision in my left eye and then I'd be completely blind. That took a toll on my wanting to be social. I didn't want to go out because I was afraid of what my eye would look like and what people would say about my eye. I didn't want to perform stand-up comedy anymore because once I almost fell off a stage because I couldn't see the edge of the stage because of the bright lights and the darkness of the audience. These challenges, these hurdles that I have had to deal with over the past 20 years pays a toll. It takes a toll to where I don't know whether I want to move forward. And that's just being realistic. And I understand that many of us are dealing with the same things and we all have our different problems that we have to deal with. The struggle for me is just knowing whether I'm ever going to be able to stay at this level of my vision. At least I'm able to see and able to work and able to do the things that some of the things that I still like to do, like photography and podcasting, things of that nature. But how long will it last? How long do I have to continue to prove myself at work? What happens when I decide to retire? It's all part of a very stressful and very depressing process in my life. And I empathize with anyone having to live with this condition and to be able to function every day and to actually want to get up and function every day. These are the types of things that we deal with on a daily basis. And I hope at some point someone will understand what we deal with and will be able to help us find more support, more resources to where we can actually continue to live our lives in a way that we're free from the stress and the pain of dealing with this condition.
Hello, my name is Arthur. I'm 46 years old and I live in Middletown, Delaware. My wife Candace has type 1 diabetes and diabetic retinal disease, which Candace had when we met 12 years ago. At that time, she had already been living with DRD for about 5 or 6 years, having undergone many laser treatments and eye surgeries to try to slow the disease. By the time we met, those treatments had restored enough of her vision for her to manage daily life, but the pain and invasiveness of those procedures still haunted her, and the fear of the disease progressing continues to be a heavy weight that we all carry. Right now, DRD has left Candace with very limited vision in her right eye, and she relies almost entirely on her left eye, which worries us both as we grow older, not knowing how or for how long the vision in her left eye might last. On Candace's worst days, her blood sugar or insulin levels fluctuate, and she can lose her sight completely. And during those moments, she depends on me and our 4-year-old daughter Chandler to help her get what she needs in order to stabilize her levels. The threat of total vision loss during a low, especially if she's away from home or without help, has greatly limited her independence. On one occasion, I remember receiving a panic phone call from Candace while I was in an important business meeting. Her speech was slurred and incoherent, and she was trying to tell me that she was low, but all I could hear was Chandler, who was a baby then, crying in the background. I left the meeting and rushed home to find Candace lying on our bed, unable to see, barely able to move, and Chandler crying in her arms. It was instances like that that has made us fearful of me leaving Candace for too long and prompted us to teach Chandler, as a toddler now, to be constantly aware of a drop in Mommy's blood sugar. Chandler will shout out, "Mommy sugar," when we hear Candace's Dexcom warning start to beep. And we've taught Chandler how to be Mommy's eyes when Candace does have a low. We've trained Chandler how to find Mommy's juice in the refrigerator and guarded her not to drink it. Another difficult time for us comes when Candace's quarterly and annual eye appointments come near. The nights before those appointments, her anxiety goes through the roof due to the memories of the painful injections and treatments and the worries that the doctor may find something wrong, especially in her left eye. So on appointment days, her stress and temperament affect everyone in her household, and where she's normally cheerful and pleasant, her demeanor becomes short and snappy. When the appointment news is good, it's like a relief so great that all of us want to celebrate. And that feeling kind of lasts until about a week before the next appointment. I love Candace deeply. Candace is the wife that I prayed for. She is the mother that she never thought she could be because of her type 1 diabetes complications. She is a sister. She is a daughter. She is a friend. Candace, she bears the scars from DRD, both physical and emotional. And those emotional scars have taken away our comfort and our desire to be independent, her desire to be independent, rather, and has limited our ability to live what many would consider to be a normal life. The physical scar of her relaxed eyelid from her numerous treatments has made her more self-conscious about her appearance, and we live in constant fear that she could someday lose her sight entirely. Candace even experienced a low on her wedding day and nearly wasn't able to walk down the aisle. Since then, the possibility that she could miss birthdays or graduations or holidays or other milestones that we cherish, that worry never truly leaves us.
Hello, my name is Nina. I'm 39 years old and I live in Sarasota, Florida. I've lived with type 1 diabetes for 34 years, and I'm here today as a patient living with diabetic retinal disease. This disease has not only affected my eyesight, but it has also changed how I live. Diabetic retinal disease brought a level of fear that I was not prepared for. It threatens something most people take for granted: the ability to see, to feel safe, and to live independently. In 2021, I was diagnosed with mild diabetic retinopathy. Aside from wearing glasses for nearsightedness, my vision still felt normal, and I was told to simply monitor it. But waiting while something progresses inside my eyes was terrifying. I lived with constant anxiety, wondering when things would suddenly get worse. In the fall of 2023, it did. I noticed a dark circle in my vision while my mom was driving. She couldn't see it, and soon after, I learned I was bleeding inside my eye. From that moment on, everything changed. I began living in panic. Every floater, flash, or shadow made my heart race. I felt like I was always waiting for the next hemorrhage. I stopped exercising because I was afraid movement would trigger another bleeding. I became afraid of lifting anything heavy. I couldn't carry groceries. My vision was so compromised that I began bumping into things. I couldn't shop independently anymore. Even basic chores and errands felt unsafe. Something as simple as doing laundry became difficult because bending down made me afraid of worsening the bleeding. My life became a constant calculation of, is this safe to do? I withdrew from friends. I couldn't explain the fear I was living with. My world became smaller, quieter, and isolated. Even watching TV felt risky. I relied on audiobooks and podcasts just to feel connected to something. I also carried shame. I felt like this diagnosis meant I had failed. Even though that wasn't true, the stigma around diabetes made me feel judged, as if complications only happen when someone doesn't try hard enough. That emotional burden made everything heavier. The bleeding continued to progress, and the vision in my right eye worsened. One day, a few months after my first bleed and undergoing laser treatment in both eyes, I was sitting after work watching TV when suddenly my vision filled what looked like water. My vision became slow, distorted, and frightening. Then bubbles appeared, and within moments, my entire vision was filled with blood. The only way I can describe it is like a gory horror movie. Except you cannot turn it off. You cannot run away from it. It is happening inside your own body. The blood had streaked my vision as if parts of it were completely covered in these red bloody streaks. In 2024, I officially became blind in that eye. That was devastating. It was no longer just fear, it was reality. I left my condo abandoned as I could no longer live independently. I became dependent on my parents in ways I never imagined. I couldn't drive, I couldn't manage daily tasks. I felt my independence slipping away. Work became harder too, as my job requires 8 hours of screen time and computer time. Bright screens strained my eyes. I changed everything to dark mode, enlarged fonts, and pushed through severe dryness and discomfort just to keep functioning. The fear followed me into everything, even food. I questioned supplements, medications, even things like ginger or turmeric, because suddenly everything felt like it could lead to bleeding. I stopped traveling because I was afraid of being far from home and not having access to my retina specialist if something went wrong. I used to love seeing the world and traveling, but this disease made me stay close to home out of fear. Even now, after over a year from a vitrectomy surgery in my right eye, I live with floaters, flashes, distortions that curve numbers and letters, and constant uncertainty. The fear doesn't disappear just because vision improves. Diabetic retinal disease is not just about eyesight. It is about losing peace of mind, freedom, and the ability to live without fear. Thank you for listening and for making space for the patient voice. Because what is at stake is not just vision, it is life.
Wow. Thank you to all of our panelists for being so brave and willing to share your experiences of living with diabetes and experiencing vision loss or being at risk of vision loss as a result of DRD. It's really helped us start to understand what it is to live with this condition, and we can now, for the first time today, expand that discussion to all of you in our live audience, other patients and care partners, and have you weigh in and share your experiences, again, of living with or being at risk of vision loss from diabetes. If you would like to share your experiences, you can call into the program by dialing 1-703-844-3231. And that's 1-703-844-3231. When you dial that number, you'll be connected with our operator who will take down some information, and then we'll be able to bring you into the program. But I'd first like to get us started with a couple of polling questions to get us all thinking about this topic and sharing some of your experiences. So for our patients and caregivers only, again, you can scroll down under the player on the webpage you're following along. You'll see a link for pollev.com/DRD-PFDD. You can click that, type that in, open up on your phone, keep that web page up throughout today's program. Every time we go to a new question, it will automatically appear. So our first question as part of this session is we'd like to know which of the following vision loss or DRD-related health concerns have you or your loved one ever had? And you can select all that apply. The options are A, reduced visual acuity, for example, blurry vision, B, reduced visual field and peripheral vision, C, retinal bleeding resulting from floaters, spots, specks, or shadows, D, difficulty seeing in low light or nighttime, E, depth perception impairment, F, light sensitivity, G, vision loss episodes, H, visual distortion or altered contrast perception, I, visual fatigue and eye strain, J, cataracts, K, anxiety or depression, or L, some other health concern that's DRD related or relates to your vision loss that you or your loved one have ever had. I will point out this is our first question today where our respondents can select more than one option. So the percentages you're seeing on the screen are not a percentage of people who have made a selection. It's the percentage of overall responses. So I like to think of these blue bars as a little bit of kind of like a relative ranking from our participants today.
And I think the distribution, again, looks very similar to my personal experience, both as a clinician, but also as Mary's husband. In particular, she started to have difficulty seeing in low light and then with peripheral vision. early
Yes.
in the course of her disease. And then, of course, it progressed to significant loss of visual acuity as the disease progressed.
Yes. So as we're seeing, as some final results are trickling in here, that the reduced visual acuity as well as difficulty seeing in low light or nighttime are some of the top direct vision loss related health concerns. We also see anxiety and depression up there being reported quite high. After that, we see the retinal bleeding, as well as visual fatigue and eye strain, and reduced visual field and peripheral vision is some kind of in the middle. But what really striking to me is how many people have reported so many of these different vision loss and DRD related health concerns, including some others that we didn't have listed here. And we certainly want to hear about that. We're going to do one more polling question here to get us started. So you'll recognize the response options here. They're the same as the last question. But here we want to know which of the following vision loss or DRD-related health concerns have you or your loved one ever had? And you can select up to the top 3 of those, of the greatest that have been most impacted. The options here are A, reduced visual acuity, B, reduced visual field, peripheral vision, C, retinal bleeding resulting in floaters or other visual debris, D, difficulty seeing in low light or nighttime, E, depth perception impairment, F, light sensitivity, G, transient or prolonged vision loss episodes, H, visual distortion or altered contrast perception, I, visual fatigue or eye strain, J, cataracts, K, anxiety or depression, or L, some other DRD or vision loss related health concern that represents a top 3 most troublesome of those.
Yeah, and just thinking about contrast perception, color discrimination also is a factor in many people's descriptions of visual loss.
Yes. So as you're making these selections, I'd like you to think about the why behind this. We saw in the last question, people reported experiencing multiple of these different symptoms and health effects. And so here, as you're having to select the top 3, as it stands, it looks like seeing in low light or nighttime is being reported as perhaps the top, followed closely by the visual acuity and the anxiety and depression, as well as that retinal bleeding that results in floaters and other visual debris. But another thing that stands out to me is that every single one of these different health concerns is in some number of people's top 3 of those, of all health concerns. So a wide range of different top concerns we're seeing reported. So thank you for participating in the polling. You can keep that polling webpage up, and we'll be coming to some questions a little bit later here. I would now like to welcome our Zoom panel here, some of your peers with diabetes and care partners. So welcome to the program. I'd like to kick this discussion off with you all. And maybe, Michelle, we can start with you as you're thinking about the wide range of the different symptoms and health effects. What things are most troublesome or most worrying from that list?
Good morning or good afternoon to wherever your time zone lands you. My name is Michelle. I am here today from Park City, Utah. I was diagnosed with DRD in January of 2017. I have been living with type 1 diabetes since infancy for 41 years. I would love to share with you that one of the main symptoms that seems to affect me the most, and I apologize if I get a bit emotional, sitting here and listening to how others have been affected has given me an emotion that I haven't felt in a bit. But the inability to see in low light has been something that has affected me. I'm 41 years old. I'm a stepmother. I'm a wife. I am a former teacher. I'm a volunteer in my community. I have worked in emergency services, and I have worked in outdoor emergency care as a ski patroller in the past. And all of these things have been affected. I have difficulty in picking up my stepdaughter from events and school events at night due to vision problems. I had to resign from ski patrolling in my community this last year because I was having difficulty seeing terrain in low light and also in snowy conditions. Being a wife to my husband where I don't want him to feel as though he has to be there for every single moment. I want to feel that independence. So losing some of those things in there, having to do specifically with needing my husband to pick up for me from where I can't drive a vehicle, where I struggle to go through the house or take my dogs out for a walk at night. Simple things like that are affected. And the inability to continue doing a job that I absolutely loved, that I worked towards for years, that I went and found additional education and certification to do. It has really affected me mentally, emotionally, socially, made me feel withdrawn. And just one symptom out of the list of many that I have, that is the main one to stick out that has affected me on a daily basis, that continues to be a worry of whether or not, is this going to get worse? What am I going to be limited from tomorrow? And it's a struggle and a fear.
Yeah, so Michelle, I want to kind of unpack a little bit of your experience with the impacts of having difficulty of seeing in low light at night. Some really profound impacts that you just described. But you mentioned, it is one that you live with day to day. Can you tell us a little bit about, how long has it been since you first noticed, difficulties in lower light settings, and when you first did start experiencing it, was it, I guess, what types of low light settings did you first notice? Can you think back to when you first noticed and maybe share what that was like?
Yes, the first thing to be affected with the low light was driving, especially at night, weather related, rain, snow, different type of it. I noticed I was driving home one evening and I felt as though the windshield just wasn't as clear. The headlights that were coming on seemed to blind out the side vision of where vehicles were. And this was probably about 6 years ago. And I had a pair of glasses that I typically just use for watching movies at a theater and happened to be in the glove compartment of my car. I grabbed the glasses in hope that, hey, maybe this would help a bit, and it didn't. And I remember pulling over on the side of the road and calling my husband and saying, I can't see.
Right.
Can't see. And I'm scared to keep driving. And I remember that this is the impact now on him, where he called his best friend, said, hey, we need to go pick up Michelle in her vehicle. She's about 45 minutes away. And so that was the first time that it really hit me. And from then on out to this day, I need to have glasses or I am not driving at night. And I would say 95% of the time I am not driving.
Right. And Michelle, how much have things changed in terms of what you notice in terms of those difficulties that have led to some of the kind of choosing not to I maybe don't want to say choosing, but being forced to not being able to do some of those activities that you mentioned. Have things been since its onset, has it been relatively stable in terms of that impact, or did things continue to get worse and that led to needing to withdraw, I think, as you described it?
So the thing that it's led to is having to me voluntarily withdraw from other opportunities. It's when these things start to impact you, it's you're grieving. You're grieving a loss. You are dealing with knowing that you have lost the opportunity to continue a daily life or continue things that I took for granted. I absolutely took things for granted, running to the grocery store at night to quickly grab bread for lunch the next day. I took for granted the ability to drive over to a friend's home for an evening.
Right.
But dealing with those losses and continually grieving as these things progress and get worse, doesn't seem to be an end to it.
Yeah. Sure. Wow. Well, thank you so much, Michelle, for sharing, so many of your experiences, all from, as you said, just one of the health effects of vision loss. Jason, I'd like to bring you into this conversation as well. Again, such a wide range of different, vision and related health concerns. What kind of, was at the top of the list of things that, were most impactful in your experience?
Hello, my name is Jason. I'm from Boston, Massachusetts, and I've been living with DRD for 6.5 years. I kind of had a unique experience because I actually found out I had DRD before I found out I had diabetes. And I took a routine contact exam. They convinced me to take an optional retina scan. The lab tech was extremely cute, and so I agreed to take it. She convinced me. And when the doctor came and looked at the scan, he actually double checked 3 times to make sure he actually had my images, and came back with, to this day, I'm not sure if he really meant to say it out loud, but he announced that I had the eyes of an 80-year-old. And he had never seen anything like it. And he said, you need to go to your primary care immediately, and you need to get tested for diabetes.
Wow.
So neither here nor there, a long struggle of debating whether I was latent type 1, type 2, lots of tests, lots of specialists, lots of repeat tests. It came out that I'm actually skinny Asian, which I like to call diabetes 1.5. It's kind of a misnomer, but I have the Korean version, which is heavily genetic and heavily resistant. So because I'm super resistant, I have to take some extra precautions, as the normal things don't actually work in the same manner as they do for the normal type 2 diabetes care. Because I started this off at a much higher level, I think it, had as many as 5 edemas at once, all bleeding at the same time. I've been lucky, I guess, that they've stayed out of central vision for the most part. So corrected, my vision isn't bad, and my symptoms are much the same, but it could be a lot worse given what I actually have. Night vision's a huge, huge problem. Being able to drive at night. I live in the Northeast. It gets very dark here very early. And just having to make decisions. Can I run out to the supermarket? Can I, go to this friend's party at night? I don't want to drive home necessarily at 10 o'clock. I am lucky that those yellow night glasses actually do help. I know they don't work for everyone, but they actually do help enough where I at least can get home or drive, reasonably comfortably. I drive in the right-hand lane like an old person, but I do get there. So I think the second one is the field vision.
Peripheral field.
Because I have the fluids on the side, so my vision field gets a little skewed, and I no longer see straight lines. So if I'm looking at this computer screen right now, the edges are all wavy. And so not a big deal, but you do tend to notice it in certain things. However, my primary job, I work with spreadsheets all the time, and working at a computer between the eye fatigue and, sometimes your vision gets a little funny after looking at those, and the lines start to go, and you have to be extra careful, especially working with numbers and doing that. So it's definitely affected my work as well.
Yeah. Jason, now this is a number of things about your experience that are really interesting that I want to learn a little bit more about. Maybe first to start, really interesting, kind of diagnostic, journey that you had there, being diagnosed with the retinal disease first. If you think back to that and getting that test, and now recognizing some of these major impacts that you've mentioned, were those things that you were experiencing but maybe didn't fully appreciate at that time? Being told you have the eyes of an 80-year-old, did you feel like you had the eyes of an 80-year-old? What if anything, kind of in terms of symptoms, vision loss, maybe even looking back, were you experiencing that?
No, that was sort of the weird thing about the whole journey.
Yeah.
And even from the diabetes point of view,
Right.
I basically went from a normal A1C to an A1C of over 11 in less than a year.
Okay.
So it's very typical. It's much like late onset type 1. It just all of a sudden just happened.
Right.
And so I didn't really notice it at the time.
Okay.
In hindsight, maybe 3 months before the diagnosis, there were some clues. However, I did progress reasonably significantly from that point on.
Right.
Where even with, I know one of the videos mentioned you try and do everything right. My A1C has been around 6.4 for the entire 6 years. My cholesterol is around 150, and my blood pressure is about 110/73, give or take, and it has been. And I'm still progressing with the symptoms. So sometimes, it is what it is, and you can only try your best, which is why you do need help from other things, from the treatments or the medicine, because you can still do everything right and still progress. And I think, sometimes that can be a little disheartening too, as other people talked about. This is a real mental issue as well. I think there's a lot to it, both from the patients, from the caregivers, from the people around you. It's a lot. People worry about what happens later. My parents are both old, and I'm an only child, unmarried, and, they worry about what's going to happen to me. And conversely, I worry about what's going to happen to him and my ability to help them out as they get older.
For sure. So you mentioned there that most of the progression has happened, since the diagnosis. How long has that been? Kind of over what period of time, have things really been progressing? And, you mentioned that it continues, and that is, definitely a big worry. But kind of its course, would you describe it as like periods of like stability and then you notice a drop off, or is it like really gradual, or is it really hard to tell? Just kind of curious.
No, it's been real up and down.
Okay.
One of the nice things about being in Boston is that I'm very close to Beetham Eye in Joslin, where I'm currently a patient. I'm also in the 4th year of the fenofibrate trial.
Mm-hmm.
And so between that and then my other visits, I basically am there quarterly to every 6 months, depending.
Okay.
I always hope that whenever I have a visit and I have my appointment, at the end, they always tell me whether it's 6 months is okay or whether they need to see me in 3 months. Obviously, without even having to explain it, you know what that means. So
Right.
I'm always sitting there hoping for the 6 months rather than 3.
Mm-hmm.
Because it is out of the central vision, there's really not much anybody can do at this point, or would like to do, because, they'd rather wait till it comes to a point where it's necessary. So, you always have that fear. Is it going to get closer? Is it going to creep in? Is one going to happen before it? So, like I said, it's been up and down. I've gone from, 1 edema to 3 edemas, back down to 2 edemas. And
Right.
At one point, my left eye was worse. Then my right eye was worse. Then now my left eye is worse again.
Yeah. And does that
so
and when those up and downs, the edemas, with the example you just gave, is there like a direct corollary to how you experience vision, what you can do, during that period of time, like how outside of kind of the clinic setting, day to day, how does that change how you experience life?
Yeah, I think you definitely. Because it is up and down, there's definitely times when it's better than others, and I can definitely know at certain times.
Is there an example of how just kind of like
yeah. So mostly I don't have problems, but every once in a while, I'll get flashes, or I'll get something that's just all of a sudden it's just off, and it will go away. Sometimes it'll go away. Sometimes I'll just close my eyes for 10 minutes and relax, and it will calm. Those light bursts are pretty crazy, though, I will say. For anyone that doesn't know, Kind of watch that scene if you're old enough from Star Wars when they jump to hyperdrive, and it's kind of like that starburst is what you see, and it's the first time it's really scary, but once you have a few of these, you kind of realize what it is, and it's going to pass. So you have to learn to live with it. It's part of it. You can drive yourself crazy if you dwell on what couldn't be. Not to say that there aren't times when you're sitting there going, wow, why me, or this isn't good, or what am I going to do? That comes and goes, but like anything in life, you got to try and see the bigger picture and muscle through it.
Right. Well, thank you so much, Jason, for sharing all of that and letting me kind of dive into that deeper with you. I do see that we have a phone caller. We have Renee from Atlanta, who's a patient living with type 1 diabetes, but not yet diabetic retinal disease, who's calling in to share some of her and other experiences living with diabetes. So, Renee, I'd like to welcome you to the program. Are you with us?
I am. Thanks so much for having me. I was diagnosed with late onset type 1 diabetes in my 40s, and I founded T1D Women, and I hear from women all over the world who are experiencing vision changes due to diabetes. And women with diabetes often face significant blood sugar variability from hormonal changes throughout life, like menstruation and pregnancy and menopause. And that variability can also increase the risk of diabetic eye disease, as well as other comorbidities. And I hear all the time about how these vision changes are having real consequences, including impacting women's independence, their careers, and their quality of life. And I just wanted to share that because while I don't have diabetic retinopathy, I've heard so many things in our community. From women that are really struggling with this, as we've heard from, all the people that have this.
Yeah, and Renee, how does the, maybe, greater, variability, that is, specific to, aspects of life that, women have to go through and impact their, diabetes control, and as you said, might then, relate to the diabetic retinal disease, does that, how does that kind of combination of going through those things at the same time impact, women's ability to cope with, the onset of, diabetic retinal disease? Can you kind of maybe share, the types of things that you've heard and maybe the things that, therefore for you, maybe represent some worries?
Certainly, and while I'm not a practitioner, one of the big things that we know with diabetes for a person with type 1 or type 2 as a woman is that we become insulin resistant during certain stages of the month, even for people for type 1. So you could be dosing, and as the gentleman said beforehand, while I know he's a man talking about doing all of the right things, and your blood sugar still, sometimes it's very hard to get it within control. And you also have to be careful then of not to dose too much insulin. And I hear people all of a sudden, I say this, I've heard this many times about, like, I think about when my blood sugar is high, that what my optometrist has told me, what that does to my eyes, and that panics me. And then you're trying not to, as they call it, rage bolus, which is give too much insulin because your blood sugar hasn't come down. I personally have experienced where, certain times during the month, you're giving yourself even 30% more insulin than you would on a typical week. And you add in this, all the emotions you're going through, and then this fear of, am I not getting control of it?
Yeah, sure. Yeah. Wow. No, that's, really important to hear, and I guess, Renee, just, one other, follow-up is, for those, women, that are, kind of within the group that you've, kind of put together to help support, for those who have experienced, vision loss, how would you describe some of the biggest impacts, for them? Again, because you were just sharing some about, like, the difficulties with managing with, some of the unique, things in life that women are going through. But how does the vision loss itself, then impact, their lives and what they're going through from that point on?
I think one of the biggest things is their independence.
Yeah.
To be able to make an income for yourself, as we've heard from so many people, how it affects their job and their livelihood. And as women, to be able to, we know diabetes is expensive, to just be able to afford your supplies and then also just be able to have your own life. It's very important for women to be able to have their independence and to lose that when it comes to vision loss. It's overwhelming, and not just how and what you feel, but also affecting every portion of your life.
Right. Wow. Well, Renee, thank you so much for calling in and not only sharing your own experiences and concerns, but those of the broader group of women that you work with. So thank you so much for sharing that, and for anyone else that would like to share their experiences, we encourage you to call in. Just like you heard Renee, you can dial 1-703-844-3231, and we'd love to bring you into the program. But I'd like to come back to our Zoom panel here for a moment, and maybe Amy, we can start with you as we come back. Again, we're still exploring this broad range of different symptoms and health effects. We've heard some common themes, but a few symptoms that aren't covered quite as much. What comes to mind to you of any kind of symptom vision loss experiences that you would like to share?
Yes, thank you, Robert and James, for having me. My name is Amy, and I'm the mom of two young ladies diagnosed at ages 3 and 8, and they're now 22 and 24 years old. And I felt so compelled to be here today because I think we bring the perspective of two young people who haven't been diagnosed yet, but have lived with diabetes for a lifetime.
Right.
And my concern is, continuously ensuring that we do everything we can using every available treatment and newer insulin that's on the market to prevent that. And so really, we don't have the ability yet to prevent it. We want to do everything we can to make that happen. And just as Renee was saying, as young women in the world, I love my daughters so much. I love all their friends that have been diagnosed, and really want to represent that community. It is a terrible thing to sit here and think that this is an inevitability, that this is happening, and it's something that we can't necessarily avoid. Right. Because we are doing everything we can to make sure that their A1Cs are good, their time in range is optimal, that they are using CGM, which wasn't available when they were first diagnosed, but is today, that we are using newer insulins that work faster, and they're exercising, and they're trying everything they can to stay healthy, that this disease, this myriad of things that come and complicate diabetes is something that, despite those best efforts, can still come for my girls and all their friends in the community.
And Amy, if you don't mind me just asking, because this is a really important perspective as part of today. People, as you said, have already lived a lifetime of living with diabetes, but are anticipating having to worry about, as you described it, the inevitability, of vision loss. I guess, as they've, navigated, teenage years, now early adulthood, are there, things that, as knowing or worrying about this inevitability, that they think about, kind of whether it's day to day or pops up from time to time, are they on the lookout? Like, how do they, think about their lives and try to plan for that inevitability, given the stage of life that they're at? I mean, it's a time where everybody's, trying to make plans for their futures.
This is so true. And I can illustrate this in a story. My oldest daughter, who's now 24, she's a grad student. We've moved her in and out of dorm rooms and apartments as each year she's sort of navigated a new lifestyle and wanting to live and try a different place on campus. And one year, as we were moving her, we didn't even know this happened. But it always was a transition point in the fall, which timed around the same time they went to their eye appointments. And as she was carrying heavy boxes, it triggered a bleed in her eye. And we went to the appointment just a week later. And as the ophthalmologist was scanning her eye and looking for any possible retinal damage, he said, "Oh, I see that this has happened, that there is some blood that's pooled." And he said, "Have you done anything? Have you lifted anything heavy?" And we could correlate it back to that. But that, of course, started a little bit of fear.
Right.
Here we are in the prime of my children's lives, and their hopes and dreams are enormous. They're choosing careers where they want to give back. One is applying to PA school. The other one is working towards their school psychology degree so that they can help children in the same way that they were helped. And to have that all of a sudden come crashing down before it's even realized, before they've gotten married, before they've had babies, before they're really working in their career, to having suddenly all that independence taken away, to not being able to see the future that they've worked so hard to obtain, that seems just really unfair. And it's not the right way we want to move as a society. So my urge is to open up those new medicines and treatments, to continue to advance the things that we need to have access to, and to make it accessible to everybody. It shouldn't be something that, we hope to have. It should be something that we have. It's a tool, right? Prevention for our eyes and keeping that vision is so important for everybody. It's just as important as insulin. And so it's something we should all have access to.
Amy, another question, that as you were telling that story, comes to mind is, this is kind of like a real life reminder, right? Of, going, yes, you can trace it back to maybe lifting something heavy, but, having something picked up, in a clinic visit, provides that reminder. How have, their ability to cope, with this worry, how has that changed, if at all, as they continue to get older and are getting closer to, being, out there in the world? Have you, all talked about that? Have they kind of described that as it kind of come up spontaneously?
Well, it's a sad thing and also a great thing to have a sibling who's also diagnosed. So as the girls have gotten older, they've gone to all their appointments together. They started out in the same exam rooms, and they're only a couple of years apart. Diagnosis is only a couple of years apart. So their childhood was filled with these appointments and going to see specialists, whether it was for, their diabetes care or whether it was for other appointments to, check the other health measures like eyes. So the two of them have formed a very unique connection. I've overheard them many times, which has made me catch my breath and tear up a little bit, because it's hard to hear the concerns that they have. And, their worry is, can I have a child? Will I be able to continue to hold my vision? Will I lose a limb? Will I possibly have to deal with amputation? All of these things have been true, honest conversations in our house. We don't shy away from the hard parts. We try to embrace them and be proactive and make sure that the things we're doing are supportive to the optimal outcomes. And that's our reality. But that's also not a great thing for a young person to have to deal with, that stress, that anxiety, that worry. I say when you're diagnosed with a chronic condition, that's also the immediate other chronic condition you get, that anxiety and that worry. And, they'll tease me back and say, well, it's because my mom worries. And I do, I also, it permeates my thinking. I'm concerned and I want to make sure that they're healthy for as long as I can make it happen. So, on behalf of all the families, this is a real true thing that we all go through.
Wow. Well, thank you so much, Amy. I see we've been getting written comments coming in on this topic as well, the symptoms and health effects of DRD. Robert, what are we seeing?
Yeah, thanks, James. So Jim from Bend, Oregon says the most significant symptoms of diabetic retinal disease impacting his quality of life are the decaying of his vision so that he can't read signs or recognize people. We have an anonymous comment from an individual living with type 2 in Georgia that indicates that he was actually diagnosed with type 2 diabetes at age 13. And then got diagnosed with retinal disease at 26 when he started to have floaters, and he's now 28 and is concerned about his future. Catherine in Overland Park, Kansas, with type 2 says she was diagnosed at 20. Complications started at age 36, and she didn't take good care of herself for 10 years after the diagnosis because she thought she was indestructible and thought the complications started when you're old. So definitely paying for it now with my kidneys and vision loss, as she says. And then Lisa from Pennsylvania says, the blurry, distorted vision makes everything harder. I get dizzy and bright lights are painful. I need sunglasses indoors. My vision changes daily, actually minute by minute on my bad days. My glasses are no true use anymore.
Wow. Well, thank you to everybody writing in as well. Keep those comments coming. Again, you can use that form that's under the player on the webpage you're following along today. I know that we won't be able to read all of the comments, but we do receive them all, and we'll be incorporating them all into the Voice of the Patient report. We've already been talking a little bit about not just the symptoms and health effects, but the impacts on daily life. Those two things are so intertwined. But I do want to go to a polling question on this topic and get a sense of the broader audience. So if you can go ahead and click on that link under the player, go to pollev.com/DRD PFDD. Our question here for you is, what specific activities of daily life are most important that you or your loved one are not able to do or struggle with due to vision loss from diabetes? And you can select up to the top 3. The options are A, driving or traveling independently, B, navigating stairs, curbs, and uneven surfaces, C, moving confidently in unfamiliar or low-light environments, D, reading or performing other visually demanding tasks, E, recognizing faces and maintaining social relationships, F, participating in recreational activities and events, G, performing household tasks, H, caring for children and family independently, I, managing diabetes independently, for example, the testing and appointments, J, managing school or work responsibilities, or K, some other specific activity of daily life that's important that you or your loved one either cannot do or struggle with due to vision loss from diabetes, or L, if this is not applicable because you do not yet suffer from vision loss from diabetes. Again, as you're making these selections, I want you to think about, of all of these different impacts, which there are so many, why the 1 to 3 of these you're picking represents a top most impacted activity. What about your vision loss journey is driving these impacts? And as the final results are trickling in here, I think we're hearing, I have heard a little bit, but certainly want to hear more about the impacts on driving or traveling independently. That seems to be the top greatest reported daily life activity impacted, followed by moving confidently in unfamiliar or low-light environments, and reading or performing other visually demanding tasks. But again, a theme is starting to emerge of so many different things here are represented in the top 3 most impacted activities. Everything except for other is listed in some number of people's top 3. And so we do want to hear about that diversity of those different impacts. And again, you can call and write in to do so. But I'd like to maybe start this discussion off with a phone caller. I know we have Adriana from Falls Church, Virginia, who is living with type 1 diabetes with diabetic retinal disease, and has some specific impacts on life that she would like to share. So, Adriana, welcome to the program. Are you with us?
Hi. Yes. Hi. Thank you for having me.
Hey, Adriana.
I'm Adriana. I've had type 1 diabetes for over 38 years, and I have been living with DRD for probably a little over 20 years. I've had my first bleed a few weeks after my son was born 12 years ago, and I have been living with bleeds ever since, getting injections every 1 to 4 months. And, I deal a lot with, problems driving, especially at night. When I have a bleed, I am not able to drive at all. Makes it hard to take care of my son. I can't drive him to school.
Yeah.
I can't pick him up from activities at night. When he was a child, he had a severe asthma attack, and I had to take an Uber to the emergency room because I couldn't drive him, and there was no one else around to get him there. It's scary having your independence ripped away from you. When you're doing everything you can with your diabetes, and then it's just your vision goes. It's really difficult. I've also had a lot of problems with depth perception, and even eating in restaurants can be difficult because of the low lighting, and traveling, going to unfamiliar places, not knowing what, if there's anything on the floor that I'm going to step on, or a step that I miss. I've fallen before because I've missed a step.
Right. Adriana.
And it's also prevented me from having more children because I've had to have so many injections that I can't go long enough between injections to actually have a pregnancy.
I see.
So it's prevented us from having any more children.
Wow. Wow, Adriana, thank you for being willing to share all of those things and including the impacts on family planning. Adriana, you talked about, your bleeds. Really you can't drive when you have those bleeds. The vision loss is more severe, or difficulty seeing is more severe. Can you tell us a little bit about, how often it is that you're experiencing those bleeds, and how long they last, just, given how big of an impact it is that you described, how much are you having to live with that?
The bleeds are really quick, but the problem is that the blood stays in the vitreous for so long, and it can take a couple months to really dissipate. And even then, I still have little floaters that are left over from bleeds. And it happens, for a while it was happening continuously. Now I'm able to go a little bit longer without a bleed. But it takes a very long time for it to go away. So the impact is constant.
Yeah. Wow. And I think you described it as it can be months, and even then there's still some kind of floaters, do you ever get to a kind of, back to, kind of baseline, back to pre-bleed before the next bleed happens, or, what kind of what's that period of time look like for you?
There's times where I've never gotten back to my pre-bleeds.
Right.
Yeah.
My vision has never been back to that. But it does get back, enough so that I can function. I can, as long as daytime driving is okay, I can, help my son with his homework. I can do those things to a certain extent, but it's never the same. My vision will never be what it once was.
Yeah.
And I worry that the more bleeds that I have, that the normal that I have now is no longer going to exist.
Yeah.
It's going to get worse.
Yes. Wow. Well, Adriana, thank you so much for being willing to call in and share what you've been going through. I'd like to come to our Zoom panel here and keep on this discussion of the impacts of vision loss and the even the risk of vision loss on daily life. Eugenia, I'd like to start with you here on this topic. There was a long list of impacts. What are the things that are most challenging or worrisome from that list of ways that daily life can be impacted?
Yeah, thank you. Thank you for having me. And my name is Eugenia. I've been living with type 1 diabetes for more than 30 years. And also, my husband has been living with diabetes LADA for over 15 years.
Wow.
So we speak diabetes here.
Yes.
And the impact is, well, I just came back last Monday for my review. And the doctor has been telling me that I have some diabetes in my eyes. And when I asked her what that means, was you have mild retinopathy. Nothing to do. You have to, do whatever you are doing to continue stopping, not progressive. But the impact that it has is that, and especially now that I'm hearing all these stories, because let me tell you, I don't know everybody else, but for me, hearing about complications is something that we know, but we don't want to know until we have it. So we don't get deeper on that subject until we hear you have a mild retinopathy. It's been there for the last 5 years or so, but is there. And now hearing how life-changing is to have retinopathy, or it's hard.
Yes.
It's something, because I realize right now that I really enjoy sunsets. And not be able to do that simple thing that, as Michelle said, you take it for granted. It's really scary. Not be able to be independent. I'm not really independent woman. I like to travel. I like to do everything by myself. And having two people that lives with diabetes at the same house with the same risk. And thinking that we are in the middle maybe of the life, we have hopefully another 4 years to live, is like, wait, what's going on? So when we went out of the consult, the practice of the doctor, me and my husband were saying, like, what can we do? Our A1C is below 6 for the last 5 years. Timing range over 85%. It's like, what else can we do? Is there any treatment to stop or maybe reduce the damage in the early stages? It's something that we are questioning, and the bad thing is that we don't have answers. So that's scary, because you see the perspective of a life. Because somehow, hopefully not, you are going there. Maybe you will not have complete, blindness, but it will stop. And it's scary.
And Eugenia, how do you and your husband, cope with that? As you described it, doing everything that you can, using the tools that you have at your disposal today, but still having that uncertainty of and kind of expectation that this is what's in your futures. How kind of day to day today, how are you coping with that?
Well, at first, every time that I hear about the disease, I try to get a little bit deeper on that. And I realized that it passed 2 days before I look for mild diabetes retinopathy. So I understand that I was blocked. So when we start talking, we, try to do our own research, be conscious about where we are standing. And also, something that came to my mind, it was like, what have you done for all these 30 years? But as Michelle said, we were diagnosed when, I was checking my blood sugar with urine. So we didn't have all the tools that we have now. Luckily, we have access for most of the things. I know that we are so lucky for that, and that we work for that. One decision that we make, it's always thinking about diabetes insurance, and then we take the decision. And how we cope is that, okay, right now is, it's not progressing, it's there. So we embrace ourselves to say, we are lucky and we are doing the things that we have to do. And I don't want to say forget ourselves, but, embrace ourselves for the things that we didn't know. And we did the best what we had with what we had. But be confident, just confident that researchers are doing their job and they're doing something. And things like, for example, this panel, this give me hope because you are listening to us.
Absolutely.
And you are listening our fears. And maybe that somebody say, hey, maybe we want to study something for the mild retinopathy, and that will be amazing.
Absolutely. Well, that's exactly right. And what today is all about, hearing, so many, individual sets of experiences and perspectives, is going to help guide that as well with our colleagues at the FDA. Michael, I want to bring you into the conversation. Again, such a wide range of different impacts on daily life. What are the things that have been most, challenging or impossible?
Hi, everybody. I'm Michael. I'm from the Finger Lakes region of New York. I've been living with diabetes for 30 years this year. I've been living with diabetic retinopathy for 11 years this past week. What are the biggest challenges? And it was interesting when you had the poll up before. I was thinking about that again because I'm third generation diabetic eye disease. My father and my paternal grandmother both dealt with it. For me, it is, from a factual point, in looking at those points, the biggest issue I've had is a lot of falls because of my depth perception and sometimes being in unfamiliar areas. The one I didn't check was driving, by the way, but I was driving in a snowstorm last night. So surprisingly, I'm still able to work through the night vision here and there. But I think most of all for me, I noticed my issues kind of like Jason. I was working in pharma marketing. I was a project manager. I couldn't see my spreadsheets. And then I was in New York City. So then I was walking from the agency down to the PATH station. And I started seeing the floaters when I was looking at buildings and things like that. And it just immediately became apparent. And unfortunately, like several others have mentioned, I wasn't taking care of myself. And we ended up finding out I had this plus about 3 other conditions.
Yeah.
And that's the thing for me also, that's key. What is the most difficult? I am that person with all the conditions, with the cardiovascular, with the chronic kidney, with the microvascular, with the amputation, with the, and we could go on for a little while longer. But the key point is it is a daily, everything goes from a daily basis to minute. It just depends on how you wake up that morning.
Yeah.
And the hardest part for me is with the diabetes overall, there are things that have been taken away. With the site, though, it also helped drive me towards working with an international organization that focuses on vision and diabetes.
Yeah.
And working locally. And that's the thing. It's tough. And I think the number one thing that is the biggest problem, and everybody has said it, is basically the mental fatigue. And that is one of the least healthy. I have 5 children, 28 to 21. I have 2 stepkids. Married a second time.
Yeah.
I'm a caregiver to my mother who we moved up here from outside New York City, and same type thing. It's like I was at the endocrinologist for a last minute appointment for her the other day, and to have to take in that space. So yeah, I think that I would have to say, other than the unsureness and things like that is a key.
Yeah.
But also with having cataract surgery and probably well over 100 shots of 2 different direct injections. Yeah, it's been a fun path, but I have to tell you, it's given me something to talk about of value. And everybody here who on our panel here, as well as the callers and what was read by Dr. Levine.
Yeah.
Fantastic. And I've been in focus groups for many, many years, but it's just really fantastic to hear, and thank everybody for, being out for that reason.
Yeah, well, Michael, I have a couple of things I want to dig in a little bit more with that experience that you just shared. First, I want to go back to the falls, because we haven't heard a lot about that yet today. And you mentioned, depth perception being an issue related to that. I mean, I guess you also mentioned just kind of, the day-to-day burden. Do you, I guess, first, can you kind of tell us a little bit about, is that as far as something you're still experiencing? Is, how often were you falling? And then, once you kind of tell us a little bit about your fall experience, I'm just curious, during periods where you experience falls, are those things that you can predict? Like, are you having episodes, with your vision, or periods of worsening, or is it something else that is hard, there and ever present, that was leading to those falls, if that makes sense?
And it's an interesting point on that is I've taken some really interesting falls in interesting places, to say the least. And also, when I had the toes amputated, I actually crashed a knee scooter into a door frame, which threw me and broke my hip.
Oh my goodness.
So now I've had the balance issues, the neuropathy, and then also the sight. So yes, I find that it's obviously gotten better, partially because of certain health items, but it's a lot of muscle memory where you even in a house or things like, it just doesn't, it's, how can I explain this in the simplest form? For me, it's almost saying, I don't worry about necessarily going blind, because if it happens, c'est la vie. I've had so many other things happen. We'll make it work. Somehow we will make it work. I'm also 57, so where the perspective I am in this group is obviously a bit older.
Yeah.
The thing is, you want to make sure that you're being preventative, but not totally risk averse, because we do need to live our lives. But I think Michelle immediately hit it off in the beginning about certain things just having to stop. It's either for your safety or the safety of others.
Yeah.
I was laid up in the hospital for almost 4 months, back in late 2024. So do I want to go through that again? No way. So I pick and choose carefully. And even now, the latest thing I'm dealing with is arthritis and trigger fingers. And I'm a guitarist. Right. Well, it's kind of causing a whole nother pathway to work on. So the falls was also something I saw of my father. So, and I think it was some of the pre-signs beforehand. Right. But I will say, when I go for treatments, or not for treatments, for checkups every 12 weeks, a lot of times I don't notice it if I'm sitting here looking at you, but they'll be like, okay, cover left, fine in the right eye. Cover right, oh boy, you can see it. But you don't see it because the compensation level between the two eyes, when you have two eyes with vision, will cover it up for a while.
Yeah, wow. Well, thank you so much, Michael, and thanks for letting me dig in a little bit there. I do see we have a phone caller I want to bring into this conversation. We have Krista, who lives in Ann Arbor, who's a patient living with type 2 diabetes and not yet living with diabetic retinal disease, that wants to share some of the impacts of being at risk, has had on her life. So Krista, I would like to welcome you to the program. Are you with us?
Yes, hi. Thank you so much for having me. I've been living with type 2 diabetes for about 12 years. I'm also a community-driven visual artist, and so complications and highlighting these are something that's always on the forefront of my mind and the work that I do within the community in like broader, aspects. And that's basically the work that I make to showcase to people. And it's the anxiety is always there, and like the things that I make work about and I talk and I research about, you can say these things, but you don't actually fully grasp what's happening until they happen to you or a close family member or friends. And the anxiety is just real. Like it's having the constant diabetic mass going in your head, and then, also trying to work and do those things is kind of astonishing what we're all capable of.
Right. And Krista, I mean, this is really important, that we saw in the polling, anxiety and depression was rated so highly, and to hear, that that's the case, even for those who haven't, started experiencing the vision loss. I guess, in terms of your life and how you, think about, your future, does that anxiety and that, having to, try to anticipate something's directed, that's so core to your, career as a visual artist, I guess, how do you, how do you think about those, worries, and does that change, how you plan and think about, your future.
Yeah, I mean, I often tell people I got art degrees because I wanted my life to be a little bit more complicated. So that's not, I wanted it to be a space where I could always overcome, like the things that life throws at you. And as of right now, I'm not thinking of, I guess, compensating for them as much as I am trying to allow, I guess, an immersive environment for the work. So I'm opening up a lot of different avenues so that the work can be very broad at different times in my life. That way I can still make work and still be tired or still have, not awesome diabetic days or any of those other health problems that come with being diabetic.
Right.
You just kind of have to be really broad.
Right. Yeah. Wow. Well, Krista, thank you so much for being willing to call in and share some of your experiences and perspectives. I know that we've been getting a lot of written comments here as well, so I want to check in with you, Robert, on this topic.
Yeah, thanks, James. On the topic of impacts on daily life, we have from Tina, who's living with type 2 in Dallas, Texas. She says, my job is affected because I have trouble with distorted vision up close. And I've went from no problem working in front of a computer for long hours back in October to now in February of this year, scared to death that I will not be able to keep my job if this progresses any further. And Stephanie, also living with type 2 from Milwaukee, kind of echoes something that Adriana had said earlier. She says that my eyes were perfectly fine until I had my son, almost 2 years postpartum now, and just had my first cataract surgery, and now likely to have a vitrectomy in the coming weeks. Always wanted to have one more child, more than one child. But I'm so terrified to finally get my eyes to a stable point that I'll possibly have to go through this all again. So I'm feeling heartbroken at the thought of being done with having children. Let's see, from Susan in Ireland, she says that driving social events, when you're wandering around peering at people to find the one you want to talk to, crowds where you lose your family or friends because you can't see from a distance, airports where you can't read the info, on a board, and then Lisa, living with type 2 from Pennsylvania. For me, it's having to give up the things I took for granted. Independence being number one. My art supplies sit waiting for me to pick them up again. Life changes when you realize you can't even run to the store when you run out of toilet paper.
Wow. Such a broad range of impacts, and some common themes arising as well. But thank you to everyone who's been writing in. Please keep those coming. I want to broaden the discussion one more time here. Again, everything we've been discussing has kind of been building, and we've been hearing some of this, but I want to go to a polling question on worries for the future. So if you can, one more time here, pull up that webpage, click on that link under the player, go to www.pollev.com/DRD-PFDD. For our patients and caregivers, we want to know what worries you the most about your or your loved one's condition in the future. And again, we want you to select up to the top 3 of those greatest worries that you have. The options are A, worsening visual impairment or going blind, B, unpredictable or sudden vision changes, C, loss of independence or inability to live autonomously, D, the inability to drive, E, emotional and psychological decline, F, loss of identity, confidence, and sense of self, G, the inability to safely navigate the environment leading to injury, H, inability to continue working or supporting one's family, I, becoming a burden on family members and care partners, J, the inability to participate in meaningful life moments and milestones, or K, not knowing how vision loss from diabetes will progress. And then L, some other worry that's not listed here that represents one of your greatest worries for your loved one's future living with diabetes and future or current vision loss.
Yeah, looking at loss of identity, I think is poignant. I know that for Mary, she always thought of herself as a dancer rather than a successful actress, and it was her vision loss that actually prevented her from being able to dance.
Yeah.
And so it really did affect her sense of herself.
Yes. So as you're making your selections, think about those things. What is driving, these being the worries and impacts that you're rating as those top three. As it stands, it looks like worsening visual impairment and the possibility of going blind is being rated as our top greatest worry, followed by loss of independence and ability to live autonomously. After that, maybe the inability to drive and becoming a burden on family members and care partners. But again, just such a consistent trend we're seeing across these polling questions is that every single one of these broad range of worries, in this case, is being reported as a top three greatest worry by our audience. So I want to come to our Zoom panel here and do a little bit of a round robin, because I think this is an important question, and I want to hear from each of you on this. Maybe we can start with you, Amy, on this topic. Again, if you had to pick one of those worries, I'm sure there's many that you would want to have said are top worry on that list. What rises to the top for you?
Thank you. Yes. So one of the things that I've thought about for years actually came because I am a caregiver. I have two daughters who are in their early 20s that were diagnosed with type 1 diabetes, and they were at a young age. So at that young age, I took care of them. Mm-hmm. And one day it occurred to me that when I am gone, although they will be hopefully independent adults, there will come a time when they might not be. And so that loss of vision, that loss of ability to see what they're doing, to inject insulin, to take care of themselves, that is a fear I have. It's a true worry. Nursing homes are not set up to take care of patients with type 1 diabetes. Yeah. And who will do that? Who will be the person to support them?
Absolutely. Wow. Thank you, Amy. Eugenia, want to come here as we're going around asking you each to weigh in on this important topic of, what is your greatest worry for the future?
Also, the loss of dependency, not be able to do whatever I want to because I always do that. But I think that's the main thing. And also losing, we have a son. We want to have grandchildren, not yet, but someday. And we don't want to miss that.
Yeah. Wow. Yeah. Thank you, Eugenia. Michael, coming to you here. On this topic of greatest worry or concern for the future?
I would say when it comes to my eyesight, most of all is leaning on others. But I think for me, after what I mentioned a little while ago, safety is a very big one because, again, you go from the point that, do you really want to be laid up in a hospital for a ridiculous amount of time? And also, if it's due to, let's say, vision loss or something like that, you don't know what's going on around you. So I would say that's the primary thing.
Wow. Yeah, thank you, Michael. Jason, same question to you. What is your greatest worry or concern for the future?
My greatest worry is the vision loss. I think I wouldn't be as diligent in my diabetic care. I think because I already started at a more advanced spot, it's much more of a reality for me. And just obviously, I respect anyone that is blind and lives with that. I don't think personally I would handle it that well. So that's my biggest concern.
Sure. Wow. Thank you, Jason. And Michelle, coming to you on this topic, importantly, want to know about your greatest worry for the future?
Two-part, actually. The independence factor, because without the ability to act independently, I cannot be a contributing member in my community. Yeah. And to serve others and to be active and be involved and be socially interactive with others in the community, I fear the withdrawal that would come from that and the ability and the inability to be someone who's active, and that's where that independent piece falls. So hand in hand together, it's terrifying to think that my inability to do things on my own I will then suffer socially, emotionally. My goals to be one with my friends, my community, workplaces would be affected, and I would then become very withdrawn. And if we think about it with that loss of vision and the inability to be independent, what happens? We become homebound.
Yeah, Absolutely. Wow. Very profound, all of you. Thank you so much. We do have a phone caller that I want to bring into this conversation. We have Sarah from Ohio, who's a patient living with type 1 diabetes and vision loss. And so, Sarah, I'd like to welcome you to the program. Are you with us?
Hello.
Nice.
Welcome. Yeah, so would love to hear, anything about your experience, or as well as any, thoughts you have on worries for the future that you'd like to share.
All right. My name is Sarah. I'm from Southeast Ohio. I've lived with type 1 diabetes for 34 years. I have had PDR for 5 years, going on, it'll be 5 years in November. Basically, I've been listening to everyone else's experiences, and, it's similar to mine. Mine started, all of a sudden, I think I knew there was something wrong just because, I work in the medical field. I was a paramedic, and I work as an RN now. And, I was driving an ambulance, and my vision was, it wasn't the greatest, but it wasn't, to where I felt like I was going to drive off the road or anything.
Right.
But shortly after that, it basically just went.
Yeah.
And I've had vitrectomies, I've had cataract removal, I've had, I had to get a tube put in my right eye here recently because I had a reaction to one of the injections to stabilize the PDR.
Right.
And it's been tough. I remember when I was first diagnosed, the doctor, literally said, "We don't know if we can save your vision."
Yeah.
And at that time, I had a 6-month-old at home that, I was caring for. So, when you're faced with, you have a newborn, basically, and then a doctor says, "Hey, you may become blind." It is what?
Yeah.
The depression hit me hard at that, and we reached out to some places, and there was limited resources to help, someone that is experiencing something like this that could potentially lose their sight and still have to continue on with the daily life.
Yes. Wow. Sarah, no, this is, really important for us to hear, those experiences, and not only the, experiences with the vision loss directly and the interventions you've, needed to undergo, but, that impacts, in terms of your mental health and depression as a result of that. If you don't mind me asking, I just, given everything that you've gone through and everything that you're doing now, I think we may have lost Sarah there. But Sarah, thank you so much for sharing everything that you did. I do know that we've been getting written comments here, so want to check with Robert. What are we seeing on worries for the future?
Yeah, thanks, James. From Crystal in Indiana, she says, "I'm worried that the next step is to lose my driving privilege. I take photos, even my church ministry, and it's getting so difficult," reinforcing some of the things that we've heard from others about driving and independence. From Samantha, the biggest thing for me is coming to accept the fact that I will very likely go blind. And from Nikki in Fort Lauderdale, she says, "I'm a recruiter. My job is to look at a computer all day, but I'm worried that it will make my eyes worse." So we see the recurrent themes of loss of independence, difficulty with job, difficulty caring for a family, and ultimately going blind.
Yes. Well, this has been an incredible morning of really trying to understand what it is to live with vision loss or be at risk of vision loss as a result of DRD. In this community of people living with diabetes. We've heard so much from you all about, the burdens that you already experience, but so much of the uncertainty that you face. And it's been, really incredible, to hear that. you're really helping paint a picture for us, of what it is that this community experiences. So I really want to express our great appreciation for everyone who has participated thus far, our panelists, our Zoom panel here with us today. All of you have called in, as well as those that we had not had time to get to on the phones. And similarly, all of you have been writing in. There's been many more comments, I know, than Robert is able to read here, and it's very important that we get that to go into that voice of the patient summary report. But at this point, we're going to move on from this topic. We'll take a short 30-minute break, come back at 1 p.m. Eastern Time, where we're going to expand on this morning topic by exploring your experiences with treatment. Some of this has already started to be mentioned a little bit, but we want to understand your experiences with trying to treat and prevent vision loss. And so I encourage you to join us at 1 p.m. Eastern, and we'll look forward to hearing more of your voices then. Thank you.
Thank you all.
Good afternoon and welcome back to the externally led patient-focused drug development meeting on diabetic retinal disease. I'm James Valentine, your meeting moderator, and I'm here in the studio with Robert Levine from the Mary Tyler Moore Vision Initiative, and we are so thankful to have all of you back to this important meeting where this afternoon we're going to build on what we heard this morning. You all helped educate us on what it is to live with and be at risk for vision loss as a result of DRD. And this afternoon, we want to explore your experiences with current treatments, as well as your perspectives on what you'd like to see from future treatments. But before we get into that, I'm going to turn it over to Robert, who will introduce our afternoon speaker. Robert?
Thank you, James. I'd like to now welcome Dr. Thomas Gardner, who will provide us with an overview of the current treatments for diabetic retinal disease. Dr. Gardner is a distinguished professor in ophthalmology and visual sciences, molecular and integrative physiology, and internal medicine at the University of Michigan. He's also a Taubman Scholar and serves as a scientific co-director of the Mary Tyler Moore Vision Initiative. Dr. Gardner has led multiple major collaborative grants from organizations such as the Juvenile Diabetes Research Foundation, now called Breakthrough T1D, the National Institutes of Health, and the American Diabetes Association. Dr. Gardner is internationally recognized for pioneering the understanding of diabetic retinal disease as a condition affecting all retinal cells, including nerve cells as well as blood vessels, redefining it as a visual sensory neuropathy that progresses alongside the microvascular changes associated with diabetes. His innovative work includes using visual function testing to assess the impact of new treatments on the retina. And with that, I will pass this over to Dr. Gardner.
Good afternoon. I'm Dr. Tom Gardner at the University of Michigan Kellogg Eye Center. I'm supported by the Mary Tyler Moore Vision Initiative and the Taubman Medical Research Institute, and I'm a co-founder of Ocular DX. So let's start with the normal retina. This is a nice, healthy, normal retina, and here you can see the optic nerve that connects our eyes to our brains, the blood vessels here. This area here is called the macula. This is what allows us to see bright color and with high acuity. This area out on the side, the peripheral retina allows us to see in dim light, see movement, but not color. And that's in contrast to this person who has a form of diabetic retinal disease called diabetic macular edema. This is the most common form of diabetic retinal disease that causes vision loss. And here in the center, you can see there's swelling from leaking blood vessels. It causes the retina to swell like a soggy sponge. And here, just by treating the diabetes, that swelling went away, the swelling and the vision improved. And so this shows the importance of really just controlling the underlying disease. Likewise, with this patient, this gentleman had the swelling here, but he also had a blood pressure of about 180 over 110 millimeters of mercury, quite high. So just by controlling the blood pressure, this swelling went away and this patient did not need any specific eye treatment. So treat the high blood pressure. A third example is this patient who had reduced vision in both eyes, lots of swelling here, but by golly, also had a lot of swelling in his leg. And you can see this dimple here due to the swelling. And so the treatment was to control his diabetes, his blood pressure, and that swelling went away along with treatment with some water pills. So treat the swelling. But when the treatment of the whole patient doesn't resolve the problems, people need eye medications. And as many of you are probably familiar with, this is the way medications are placed inside the eye. And although this looks very ghoulish, it is very safe. It is effective, and it is really not very painful, although sometimes there is some burning. So the steroid medications and other anti-swelling medications are injected this way. The drugs often have to be delivered every month or two for up to a couple years, but that's still better than what we had beforehand. The other general classification of treatment is laser treatment, and this is the inside of an eye of a person who had extensive laser treatment for the growth of abnormal blood vessels. These abnormal blood vessels responded, they went away, and the patient's vision was saved. But this treatment is uncomfortable, and it causes, as you can see, all the scarring leads to loss of the peripheral vision and night vision, and so it's often combined with injections and remains a mainstay of our treatment. Going forward, though, there's extensive work going on with new medications administered new ways. Anti-inflammatory medications, such as various kinds of steroids, are put inside the eyes. But there's also a lot of work to develop drugs that have fewer side effects and are more specific for diabetic retinal disease. A molecule such as interleukin-6 is being developed in this way. Obviously, most people would prefer to have oral medications, and so there are anti-inflammatory drugs and blood vessel stabilizing drugs that are under development in this direction. So what are the challenges? Well, first of all, there's a limited understanding of how diabetes affects the retina at a cellular level. And the reason for that is because of until very recently, is a lack of human tissue and its analysis. That is changing thanks to the work of Dr. Patrice Fort here at the University of Michigan and his colleagues. In addition to not having limited understanding of what's going on inside the eye, there are also inadequate measures or endpoints for clinical trials. The eye chart where people read letters really doesn't reflect patient symptoms. And so new endpoints are being developed in collaboration with the Diabetic Retinopathy Clinical Research Network to try to bring patients' symptoms more into the analysis. And the basis for that is shown here in this slide. This gentleman had diabetes, but had 20/16 vision, better than normal, and what we think is mild retinopathy. But the slide on your right shows areas in which the sensitivity of his retina is markedly reduced here in these gray and dark areas. So this is the equivalent of having advanced glaucoma, even with no symptoms. And we're still learning how to interpret this information and how we can use to treat people. So going forward, we're working very hard to make this normal appearing retina the retina of somebody with longstanding diabetes. So thank you for your collaboration and interest in this work. And we will look forward to your input later today. And back to you in the studio.
Thank you, Dr. Gardner, for setting the stage for our discussion around current and future treatments. So now we're going to move into our second session of the day, which is to understand the patient experience with current treatments and to hear from patients and care partners on this important topic. So some of the questions that we want to explore and have you all weigh in on as we progress through this afternoon, you'll see them here. We want to understand from you what it is that you're currently doing to manage your or your loved one's DRD-related symptoms or to prevent the onset of DRD. When we want to, in kind of understanding what it is that you are doing to manage symptoms or prevent onset, we want to know, of course, about any medications, direct medical interventions that you might be using, medical devices for monitoring, but also a broader range of things, whether that's participating in clinical trials, but also things that you're doing in your daily life, lifestyle modifications, diet, exercise, and the like. Anything that a person with diabetes that's experiencing DRD or at risk might be doing to make life a little bit easier or to, again, prevent that onset. So with that in mind, we want to understand how well that broad range of different treatments and management approaches helps to treat or manage the most significant symptoms and health effects of you or your loved one's vision loss from DRD. In thinking about those different approaches, we also want to understand what are some of the most significant downsides or trade-offs that come from those, whether that's side effects, burdens of keeping up with the strategies, and we want to know how those things themselves affect your daily lives. Once we've spent some time exploring your experiences with current treatments, we're going to shift gears and look towards the future. And we want to know, short of a complete cure, what specific things would you look for in an ideal future treatment for vision loss from DRD? Another way to think about this is if a new trial, a research trial were to come along or a new treatment were to come along, what factors would be important to you in deciding whether to participate? And again, that could be a treatment for vision loss once it's onset. It could be something that comes along earlier in the vision loss journey, or something, again, to help prevent the onset of DRD for those at risk. So we want to hear from the broad population represented here today. To help us get started on this topic, it's my pleasure to introduce our second panel. We have Nadia, Helena, Heather, Anita, and Ricardo. Nadia, take it away.
Thank you, James.
Hello, my name is Nadia, and I have had type 1 diabetes for 33 years. I'm currently 37 years old. Over time, type 1 diabetes has affected both my kidneys and my eyesight, and unfortunately, seeing floaters have become the new normal for me. This has led me to experience that I never thought I would imagine that I would have to go through. I have undergone multiple laser treatments and eye injections, which I know are very necessary, but they are never easy. I was in college and I had no knowledge about diabetic retinopathy. I went to my routine diabetic eye exam and was told that I had bleeding behind my eyes. Now, I didn't even know that there was anything wrong with my eyes. After that, I had no time to sit with this information. The same day, they started the laser treatments. I was honestly very scared out of my mind, and for a few months after that, I had more laser treatments to suffer through. This experience made me miss school and work for each treatment and figure out how to not fail out of my classes, along with managing my diabetes and also trying to keep a social life. After months of laser and over 100 laser spots, I learned that eye injections would be the next best thing for me. The thought of having a needle go into my eye left me overly stressed out. When the appointment time came for this, my blood pressure was incredibly high and I almost rescheduled. The anxiety leading up to the appointment is something that I will never forget. The doctor gave me numbing drops, but of course, those numbing drops, they don't take care of like the fear from having the injections, the pressure, and just in general, the after pain. People call it routine, but for the one that's getting the injections, it's really nothing but routine. It's exhausting and emotionally draining, and there is nothing routine about having a needle shoved into your eye. I still don't know what medications were put into my eye. For this treatment, I wish that maybe I could have been put to sleep instead of watching a needle go directly into my eye. I mean, just imagine you're awake with the needle about to go into your eye. After the injections, it was very hard to see. I remember my mom dropping me off at my apartment and I just laid on the couch for the rest of the day. It felt like there was sand in my eyes. This was the worst feeling ever, and yet I had to take more time off from school and work. After the injections, I've had multiple eye floaters, which I fear may never go away. The whole event was daunting because I had no idea what was going on. I was just told that there was bleeding behind my eyes and nothing else. Now I'm just wondering when I will have to experience one of the worst times in my life again. I have dragged my feet on going to the eye doctor because of that very traumatic experience. I feel like there must be better treatments for diabetic retinopathy. Eye injections cannot be the best we do in 2026. For people who have already spent a lifetime managing diabetes, vision loss should not come down to enduring needles in our eyes just to keep what sight we have. Laser treatments are not much better. The burning, the flashing lights, and the pain, along with the permanent damage it leaves behind, none of this feels advanced. We deserve options that are less painful. We should not have to suffer to survive.
My name is Helena. I'm 32 years old. I have been diagnosed with type 1 diabetes since I was 7 years old. I grew up in Ethiopia, where awareness of diabetes and access to specialized care were extremely limited. When I first became ill, the doctor believed that I have an abdominal problem. Near 2 days passed before I was correctly diagnosed with type 1 diabetes. At the time, neither my family nor I understood what diabetes was. There was no education, no guidance, and a very few resources available to help us navigate this life-changing diagnosis. As I grew up, I experienced frequent episodes of hypoglycemia. I would cry and shout, often leaving my parents confused and helpless. They learn through experience rather than education, without access to information or support. Living with diabetes was not only physical challenging, but also emotional isolating. When I told people that I have a diabetes, they said, "Oh, I'm sorry for that. Oh, you have diabetes." The most significant complication I have faced is diabetic retinopathy. In 2022, one morning when I woke up, I noticed a black shadow in my left eye, like a dark spot blocking part of my vision. At first, I thought it was temporary. Days passed, then a full week, but as the spots remained, I realized something was seriously wrong, and I went to the hospital where I was diagnosed with diabetic retinopathy. When I first heard the diagnosis, my world was shattered. My immediate thoughts were, how am I going to raise my child? Will I be able to see him growing up? How will I continue my job as a nurse? I was devastated. I was advised to undergo laser treatment therapy. I waited anxious and began the treatment, hoping it will stabilize my condition. But after completing the therapy, the doctor informed me it was not sufficient and surgery would be necessary. I would refer to a private clinic for further management. At the private clinic, the ophthalmologist confirmed I need an eye surgery. The experience was overwhelming. Medication was injected directly into my eye, and my eye was held open during the procedure. Tears streamed continuously, and the pain was intense. During every step of the surgery, I was not able to tell what was happening or what would happen next, which made my experience even more frightening. It was intensely frustrating and one of the most painful medication experience I had ever endured. After the first surgery, I stayed at her home for 1 week recover. I was in the significant pain and I had to strictly follow post-operative instruction while using multiple eye drops and medication. Even during this short recovery period, I lived with fear and uncertainty about my vision and my future. 9 months later, I experienced another major setback, bleeding in my right eye. Emotionally, this was devastating. I returned to the doctor and underwent a second surgery, but it was unsuccessful. This time, my recovery was much harder. I stayed in the dark room for 1 month, full month, isolated from light and normal daylight. It was an extremely difficult and frustrating period, filled with pain, anxiety, and constant fear about whether my vision could be saved. Eventually, I told I need a surgery with a lens replacement. Before the procedure, I prayed deeply for strength and hope it would be the final intervention. The surgery involved changing the lens, and after the procedure, my vision gradually improved. It took a 1 year or a half year to recover with this. Today, my recovery is ongoing. My left eye required a negative 1.5 lens, while my right eye requires a positive 1 lens, creating a permanent imbalance that affects my vision daily. Glass was recommended, but adjusting to this difference has been challenging. My message to the physicians, optometrists, scientists, and companions is simple but powerful. Behind every diagnosis is a real person, a family, and a future. We need early screening, compassionate care, and treatment that reach everyone, not only those living in a wealthy country. Today, I share my story so people can understand the emotional, financial, and medical challenges that come with diabetic retinal disease. And I want every child living with diabetes to know you are not alone. Your life has a value and your future is still full of possibility. Thank you so
Hi, my name is Heather. I'm 56 years old and I've had diabetes since the age of 12. I've had type 1 and I have had proliferative retinopathy since I've been about age 22. Throughout that process, the treatment was not that great in 1991. It was panretinal photocoagulation, and I had thousands of lasers pointed at my eyes, zap, zap, zap. And honestly, the closer it came to the retina, the more it hurt. My doctor said to me, "We're going to do this to protect your central vision. And I'm going to make sure that I do the best job that I can to protect your eyes." And indeed, laser surgery did protect my central vision, but there have been problems with that. Namely, seeing in the dark is very difficult. I always have a flashlight just to make sure that I don't trip over anything. It's very difficult to see peripherally. My eyes can't see anything really below my waist, so I bump into things, and it's very awkward when I'm trying to go across a room. My son says, "Watch out, she's a bumper car," and that's actually true. Another difficulty is seeing when it's bright out. When I was at um, the Lincoln Memorial, all I saw ahead of me, because it was sun and marble steps, was simply an ice skating rink of white light, and couldn't see down the stairs to go anywhere. So I was terrified. I mean, this is restricting to be able to not see in the light and not be able to see in the dark. My ability to drive at night is limited. And, going down the stairs, sometimes what I do is I just put my foot forward, like a child who's testing the temperature of the water to make sure that it's not too hot or cold. And what I'm doing is just testing to make sure there's a step there so that I'm not tripping. That has happened so many times, and I just am getting used to it as a normal part of life. But why should we? Why should we accept that as normal? There's so many things that I have hope for in the future. Um, if further treatments would not only just give me the central vision that I so treasure, but also protect the periphery, that would be a miracle. And, maybe there's special eyeglasses that could be made to be able to do that, or perhaps there's stem cell research that could improve my life and the lives of millions of people who have diabetes and type 1 and struggle with their vision. I would honestly try anything to be able to make sure that I can live the rest of my life as healthy, as well as I can, and to protect both the central vision and what's left, very little of the peripheral vision. I'm tired of being a bumper car. I'm fatigued by falling. I'm done with saying excuse me as I move throughout my day. I'm disappointed by not being able to drive at night because it's not safe. Most of all, I'm scared of my future. I'm scared of complications for my eyes. My eyes are so precious to me. And I'm devastated by these effects of diabetes. I hope that in the future there will be better remedies and hope for us all. Thank you.
My name is Anita. I'm 41 years old. I live in Indonesia and I have lived with type 1 diabetes for most of my life. Today, I'm speaking as someone who has experienced diabetic retinopathy and its complications, including cataracts, and who has undergone multiple eye procedures on both eyes. My journey with diabetic retinal disease did not begin with pain. It began quietly, with vision changes that were confusing and easy to dismiss. Before my vitrectomy, what I saw was not darkness, but movement. Every time I moved my head, it felt like blood was flowing downward inside my eye, like a curtain of red drifting across my vision. It was frightening, disorienting, and hard to explain to others who could not see what I was seeing. I experienced my first eye bleeding after giving birth to my second child. At that moment, I promised myself that I will do anything to see my baby. As a person diagnosed with type 1 diabetes since 13 years old, and with diabetic retinopathy after 19 years with diabetes, by the time I received treatment, my condition had already progressed. I underwent laser therapy in 2016 and vitrectomy in both eyes in 2017. The vitrectomy was life-changing. After the surgery, my vision became clear again. For the first time in a long time, I could see without fear of sudden shadows or floating blood. That clarity gave me hope and also taught me how powerful the right treatment can be when it finally arrives. However, treatment did not end there. After vitrectomy, I developed cataracts in both eyes, a known complication of the surgery. My vision gradually deteriorated again, this time more slowly until my sight dropped to around 30%. Only then did I undergo cataract surgery. Once again, surgery helped restore vision. But each step came only after something had already been lost. The cataract surgery conducted in 2024 and 2025. Over time, the treatment and management strategies had to adapt. At first, the focus was saving vision. Later, it became about preserving independence and safety. Vision loss affected my daily life in ways that are difficult to measure clinically. I had to quit playing the violin, something deeply personal to me, because I could no longer see the strings clearly enough to play with confidence. I began tripping on stairs. This year, I fell down the stairs and had an accident. Not because I was careless, but because depth perception and contrast had quietly changed. These are not always the outcomes people associate with eye disease, but they are real. Treatments may address bleeding, swelling, or clouding of the lens, but they do not immediately restore confidence, balance, or trust in one's own body. Each procedure came with emotional weight, fear before surgery, hope after, and anxiety about what might come next. The most significant downside of my treatments was not the procedures themselves, but timing. Much of my care happened after symptoms appeared. That meant treatment was reactive rather than preventive. By the time intervention occurred, damage had already affected how I lived, moved, and engaged with the world. From my perspective, early diagnosis and early care are critical. Many of the complications I experienced might have reduced or delayed if preventive eye screening and timely intervention had been prioritized before symptoms emerged. Diabetic retinal disease does not always announce itself loudly. Sometimes it whispers, and by the time it is heard, vision is already at risk. When I think about future treatments, I'm not only thinking about better surgical tools or medications. I'm thinking about treatments that come earlier, that are easier to access, and that are integrated into routine diabetes care before vision is threatened. I'm looking for approaches that focus on prevention, not just rescue. In an ideal world, treatments will preserve functional vision, not just visual acuity on a chart, but the ability to walk safely, recognize faces, read confidently, and continue meaningful activities like music. I would also hope for treatments that consider the cumulative burden on patients, repeated procedures, recovery time, emotional stress, and the fear of losing independence. As someone living with diabetes complications, I will be willing to participate in clinical trials if the goal is to prevent progression, reduce treatment burden, or protect vision earlier in the disease process. My goal will be to help ensure that future patients do not have to wait for vision loss before care begins. My experience has taught me that diabetic retinal disease is not just an eye condition. It is a life condition. Treatments matter, timing matters, and prevention matters. Most of all, listening to patient experiences matters, because vision loss is not only about what we can no longer see, but about how we are able to live.
Good day to all. My name is Ricardo from South Texas. I have been type 1 diabetic for the last 38 years. For the last 9 years, I battled significant eye complications. Before these complications, I was a college graduate in electrical engineering, fulfilling my dream to create and build a better world through engineering and industrial construction. In 2017, I lost my left eye after numerous procedures, injections, eye drops, and treatments that accelerated my vision loss due to my diabetes, according to my doctors. 3 years later, faced with a prospect of similar issues in my right eye, I was skeptical. I resisted further interventions. Due to my lack of trust from previous events on my left eye. After seeking professional opinions from three different eye specialists, they all had different ways of tackling the issue, but they all agree to one thing: to do something and to do it soon. So I came back to the original doctor that suggested a preventive eye surgery and had it done. This procedure avoided my retinal detachment, but it also left me with a cloudy and blurry vision that I never got used to. I wish my doctor would have been transparent and truthful about potential outcomes. If he would have done that, I would have been ahead. And in seeking visual impaired training and connection with organizations that help people venturing into the world of cloudiness and blurry vision. Currently, I receive Vabysmo treatment, injections in my right eye that help me maintain my vision and enable me to continue working. With aid of adaptive technologies such as zoom text, JAWS, and adjustments to my computer to be able to read and see the world through my computer. I'm also actively involved in O&M, in Braille training, and exploring assistive devices, and finding ways to adapt to devices not designed for the visually impaired, as these can also help us in our day-to-day living. My experiences have shown me the critical need for treatments and procedures that minimize the impact to patients' vision and overall well-being. A clear communication about potential outcomes is essential to empower individuals and patients to make informed decisions and prepare for changes or lifestyle changes. I urge you to consider patients' perspectives while evaluating and approving treatments, medications, and procedures for diabetic eye complications. By prioritizing treatments and procedures that preserve vision and quality of life, we can empower people to continue contributing to their communities and pursue their dream of positive and impactful legacy for generations to come. Thank you.
Thank you, everyone.
Wow, Thank you, Ricardo, and all of our panelists here this afternoon and helping share your experiences navigating the current treatment landscape and sharing your perspectives on what you want from future treatments. That we're now moving into our second part of today, where we get to bring all of you and our live audience into the discussion. And so if you would like to share some of your treatment experiences, we welcome you to call in. You can dial in now by dialing 1-703-844-3231. Again, that phone number is 1-703-844-3231. This is for our patients and care partners. If you would, when you dial in, you'll be connected with our operator. They'll take down some information so that way we can then bring you into the live program. So we welcome you to call in throughout this afternoon's program. To get us started in thinking about this topic and understanding the experiences of our audience, we're going to start with a couple of polling questions here. So for those of you who are here this morning, this is for patients and caregivers only. You can go back to that webpage. For those who are not in the system, there's a link under the player on the webpage you're following along today, or you can type into your web browser on your computer or your phone, www.pollev.com/DRD-PFDD. Again, that's pollev.com/DRD-PFDD. So our first question for this afternoon session is we want to know about the different medications and approaches that you have used to manage or prevent symptoms associated with vision loss from diabetes, and you can select all that apply. The options are A, anti-VEGF eye injections for retinal swelling, abnormal blood vessel growth and leakage. B, steroid eye injections to reduce inflammation and swelling. C, eye drops for inflammation, pain, or dryness. D, an investigational medicine in a clinical trial. E, products for emotional or psychological decline. F, laser therapy to reduce abnormal blood vessel growth and prevent bleeding. V, vitrectomy after vitreous bleeding or hemorrhage. H, vitamin supplements. I, vision aids and adaptive tools, for example, glasses and magnifiers. J, environmental modifications, things like handrails, additional lighting and reflectors. K, some other medication or other management strategy or approach that's not listed here that you've used to try to manage or prevent symptoms. Or L, if you have not used anything to try to manage or prevent DRD.
I think it's important to note that although anti-VEGF is now a treatment of choice, especially here in the U.S., laser therapy does remain a mainstay of therapy here in the U.S. and in many places in the world. And also to note that both of those interventions are late stage. Mm-hmm. And so they're really about interventions after their vision is threatened or there's been significant visual loss. And, yes. And what many of our panelists have already said is they look forward to the development of new therapeutics that can be applied earlier in disease course to preserve their vision so they don't have to have those rescue procedures.
That's right. And just a reminder, the percentages we're seeing for these questions where people can select more than one option are percentage of responses, not the percentage of people making a selection. So you can think of these blue bars as a bit of a relative ranking. To Robert's point, we are kind of grouping everyone together in these questions, where they are in their journey with vision loss and being at risk. And so we want to hear from the broad community and even in exploring, how you all are even trying to prevent DRD. In terms of the responses we see eye drops kind of being used most frequently, and followed very closely by the anti-VEGF injections. Maybe number 3 is we see that laser therapy, but a wide range of different things being reported here by our audience, including a number of other things, as well as even some clinical trial participation. We do note that a number of people have not yet used anything to manage or prevent DRD. So even for that group, if that's the response you selected, we'd love to hear about where you are in your journey and how you have made that decision to not yet try to do anything. One more question here to get us thinking and started on this topic. So we want to know, how well does your current treatment or management regimen, so all the things that we just talked about on the previous question, how well does all of that control you and your loved one's symptoms overall, or how has it helped to prevent symptom onset? The options are A, not at all, B, very little, C, somewhat, D, to a great extent, or E, not applicable because you're not using anything to treat or prevent DRD symptoms. As you're making your selections here, I mean, every one of these questions has been personal in some way, but this is one where we really want to know, how you've come up with your rating here. What treatments have come to mind? What is for the about a third of you that are saying somewhat? What does somewhat mean to you? How has it? How have things helped? But what are the gaps? For the about 25% of you that are saying that things have helped to a great extent, depending on where you are in your progression of this condition, we want to know again what that has looked like. For those who have tried things and have not had any help at all, about 5 to 7%. We want to hear your kind of what were your benchmarks, in terms of treatment goals and how current treatments have helped address those.
And I will add, though, to that, the not at all category, we do know that as good as the anti-VEGF interventions are in preventing progression, we do see as many as 40 to 50% of treatment failures or less than optimal response to treatment. And additionally, laser photocoagulation therapy has associated with it some significant side effects, including diminished peripheral vision, diminished night vision. And so all those things, I imagine, play into folks answering not at all or somewhat in terms of the impact of the therapies.
Absolutely. So thank you, everyone, for participating in this first set of polling. You can keep this webpage up as we go to different polling questions throughout the session. They'll automatically appear there. At this point, I would like to welcome our Zoom panel, some of your peers here within the community who will be sharing their treatment experiences with us as well. Grace, maybe we can start with you. We talked, we're casting a wide net in terms of what we're calling treatment experiences. And as we think about those, I'd like to maybe start with the things that have been most helpful, whether that's in big ways or small ways. What comes to mind, for you?
Yeah, so I'm Grace. I've lived with type 1 diabetes for, it's hard to keep track after a certain point, but let's just say 24-ish years, and have been navigating DRD complications for the past six or so years. And I've kind of run the gamut between injections, laser treatments, virectomy. I've done most of it.
Sure.
And I would say the biggest thing, nothing that hasn't been said, a lot of these treatments are painful and unpleasant and things like that. But I would even go a step further and say kind of one of the bigger frustrations for me personally was not realizing the side effects of the laser treatment that would impact my peripheral night vision. And just kind of those small details where I think if patients can kind of have a level set, realistic, hey, these are possible kind of side effects of these treatments, I kind of would have been more prepared for those to happen and kind of adapted sooner in a more preparation type of way than a reactive way.
Yeah.
But, I'm very grateful that these treatments do exist in their current form because they saved my vision to a point where I'm still able to drive during the day. I can do my job and kind of with minimal impact to my life other than bumping into things, but excited to see what the future holds as well.
Sure. And Grace, we'll maybe table some of those side effects just for the moment, but I do want to dig in a little bit on what you were just saying of you're grateful, that these things exist. They have allowed you to continue to do certain important activities in daily life. Has that been because those treatments, helped reverse vision loss? Is it because they were able to keep you stable with where you were in your progression? What was your personal, experience there?
Yeah, so they a little bit of both actually, and I my right eye is the problem eye, so to speak. But I have a very dedicated doctor who focused really on making sure my left eye is as stable as possible, which he has done a fantastic job at doing. So I think, you know, yes, the right eye of it all has been quite difficult, but knowing that there's a plan and a course of treatment that can at the very least preserve my vision in my left eye and kind of, you know, slow and stop that progression has been not only from a practical standpoint really great and being able to see, but also I think from an emotional standpoint, knowing that, you know, there's options. If anything seems off, I can call him. We
Right.
have a plan, and there's a kind of path forward.
And Grace, how do you define that, you know, stability? Because I think I was listening very closely, and you mentioned a little bit in terms of times like stability, and then maybe a little bit of like slowing progression. Can you kind of talk about that left eye? You know, has there been progression, and even if there has it that the slow nature of it, you know, been valuable to you?
Yeah. So fortunately, I think we've been able to halt, at least for quite a decent chunk of time. I'd say the last year and a half, 2 years almost. I see him much less frequently than I used to. So I think as soon as I had the vitrectomy in the right eye, his focus was on the left, and seeing that there was progression happening and stopping that and kind of maintaining that stability from that point forward, which is kind of where we're at now.
Right. And then you mentioned that your right eye is your trouble eye. You know, has there been anything that you would, you know, say has helped in any way, you know, with that eye, or you know, by kind of contrast with your experience with the left?
I would say the biggest thing with the right I have experienced is the kind of the dryness and just kind of the irritation, which
Okay.
eye drops have helped with tremendously. And then I would butcher the name, but eye drops to keep the pressure in both eyes under control. And I do those twice daily. But yeah, it's very nice to have, again, options to help with that dryness and that irritation.
Absolutely. Thank you so much, Grace. Luke, want to bring you into this conversation. Again, we're exploring, you know, wide net of what counts as a treatment, but, you know, have there been things that have been, you know, more helpful in your experience?
Yeah, absolutely. So, hello, everyone. Thank you so much for having me on. My name's Luke. I'm calling from Minnesota. Been type 1 diabetic going on 35 years. So, lived with this disease for quite a while. And fortunately, I am one of the rare, you know, type 1 diabetics who hasn't had much complications with my eyes or have had treatments done with my eyes.
Yes.
But I want to bring a perspective of the emotional, basically, burden that this disease can bring. It's not only, you know, high and low blood sugar, but it's all the ancillary effects that we deal with and we think about on a constant basis. So if you have any questions, you know, on the emotional, you know, standpoint of a type 1 diabetic not dealing with this disease, I'm more than happy to be a voice for that.
No, and it is really important, and you know, kind of understanding, you know, how, you know, a person in your shoes is navigating, you know, this moment in time where you're kind of anticipating. We learned a lot this morning, you know, about you know, those anxieties and worries, you know. So I guess my question for you, Luke, is, you know, both, you know, mentioning kind of the, you know, the kind of the psychosocial, you know, maybe mental health impacts. You know, how are you coping with that? Do you have strategies for dealing with that? You know, we very much do care about that as a health concern related to this condition. So, you know, what does that look like for you?
Yeah, and it's a great question, and obviously it's support groups. It's finding people, you know, who've dealt with this disease for many years, or not even many years, but are affected in so many different ways.
Yeah.
Diabetes is very unique, where it can affect, you know, one person to the other, to the other, to the other, so vastly different. In my family, personally, I've been diabetic for, again, 35 years. After my older sister caught COVID, she developed type 1 diabetes at the age of 40. And just having a support system and some people who understand that it's not just I can't eat sugar.
Right.
There's so much more that goes with it.
Mhm.
So yeah, that's one of the things that, you know, keep me going, keep me on my toes, is those support groups. And the other thing I'd love to see in the future is just lowering the barrier of care that we're able to receive. You know, maybe see the ability to go see the doctors you've been seeing, for your whole life instead of having, insurance dictate which doctor or medication you see.
Right.
Because again, everything affects us all so differently. This isn't a very typical disease where it's a one cure, one all option. And yeah, it'd just be great to have an overall barriers lesson for care.
Absolutely. Well, thank you so much, Luke. I do see that we have a phone caller. So I'd like to go to Sarah from Ohio, living with type 1 diabetes and living with DRD, who'd like to touch on some of her treatment experience. I think we heard from Sarah. She's one of our callers in the morning session. So Sarah, would like to welcome you back to the program. Are you with us?
Hello, thank you.
Hi, welcome back.
Hi. So treatments, I've had to go around. I know as soon as I was diagnosed, pretty much we started with injections immediately. I have PDR in both eyes.
Mm-hmm.
My right one is actually worse than the left. So injections, I've had the laser therapy. I end up having a vitrectomy in my right eye about 3 months after being diagnosed. We did the left eye vitrectomy after the birth of my second daughter.
Okay.
And even now I still get injections about every 4 to 6 weeks. I had to have cataracts removed because obviously the injections kind of increased the cataracts to where they needed removed, because I actually had just like minor cataracts when I was diagnosed.
Yeah.
And here recently, one of the injections that I had in my right eye turned into steroid-induced glaucoma. So I had to undergo more surgery for that because the eye drops were not working.
Wow. And Sarah, kind of, because you mentioned, that you have both eyes are affected, how would you kind of rate, obviously we heard that there were some limitations, certainly some side effects and downsides, but if you're thinking about your disease progression overall, how would you rate, those current treatments in terms of how they've, either helped or not helped with your disease symptoms?
I think they've helped some just because, like, when I was first diagnosed, like, it was kind of a shock. And then, like I mentioned the first meeting, being told, hey, we don't know if we can save your vision. You may end up blind. And then, like, going through, like I pretty much hit an all-time low in the depression after that, just because it's like, am I going to become blind?
Yeah. Yes.
Am I going to, miss, like, being independent? Am I going to miss my daughter growing up and stuff? So the treatment, I mean, there's still some depression there because it's like, every time I go in to see the retinologist, I keep thinking, maybe this is the day I don't have to get an injection.
Yeah. Right.
And then, you get an injection, so that it's kind of, man, I did not want that to happen. But, I mean, it helps because, to me, it's keeping it stable.
Sure. Yes.
I mean, it's not going to cure it. There's no cure. And, ultimately, in the back of my mind, this could become worse.
That's right.
But at least with the treatment, it helps keep it at bay to where I can still keep my independence.
Yes.
I can still, go to work. I can still watch my children grow. I can do a lot of things.
That's right.
So I think that helps.
Yeah. Well, thank you, Sarah. I mean, this has been very helpful to hear kind of the both the good and the bad in terms of where there's been some help, but also some of those trade-offs that you've had to experience. So thank you for calling in and sharing that. I want to check back in here with my Zoom panel. Maybe Candace, we can come to you, as we're, exploring, treatment experiences, maybe things that have been more on the helpful side. What comes to mind for you?
Yeah, thank you. I'm Candace. I've been living with type 1 diabetes for
for 30 years and have been living with DRD for 16 now. So very familiar in this space and obviously have run the gamut of treatments. I've also had the laser therapy, I've had injections, I've had several surgeries, and now I'm just kind of maintaining with eye drops. And so if I were to say, also, I'm also a right eye offender. I've heard, many say that the right eye is my problem eye, and I joined that crew. And the right eye is my problem eye also. But what I found most were a couple things. Of course, the drugs, the intervention from my doctors, the laser therapy, but it also the eye drops, of course. But it also, like my fellow panelists was saying, it was the support from just the community as well. Being able to have places like this where we can talk openly and freely and share what we're going through and to share kind of what our experiences are in the hopes that that the people who need to be listening the most will actually hear our stories. So yes, there were treatments that definitely worked. I had actually lost my vision in 2010.
Okay.
And so through the help of my doctors, both my retina specialist as well as my glaucoma specialist, they were able to restore my vision. I still technically cannot see out of my right eye, but my left eye is like 20/15 at this point. And so just being able to maintain the stability of my left eye, I heard someone say that earlier, that while the right eye is not perfect, that my doctors are very persistent about maintaining my left eye and my vision and preserving that vision.
Yeah, and Candace, just again to really understand that, because I think that term means different things to different people. For you, stability, has that been a absolute halting of progression? Has that been slowing of worsening in that left eye?
Yeah, so it's really slowing. There are different times where my vision may not be stable, and then my doctors do have a plan of how they attack that. It can look like injections. It can look like different drops.
Yeah.
It could look like the different ways of controlling my blood sugar to prevent like the onset of more damage.
Right.
And so that's worked over the past 16 years. Thank goodness I am in a place right now where my vision is stable. And so I haven't had a bleed, I don't think, since before my daughter was born about 5 years ago. And so that has been life-changing for me because it affects my ability and how I show up every day, how I look as a mom, how I look as, a business owner, how I look as just a friend. And, it's made a world of difference for me.
Yeah, and you said you haven't had a bleed in about 5 years. What was that like before? How often were you getting bleeds?
Yeah, it was pretty bad. As I mentioned, I had lost my vision at one point.
Yes.
The bleeding was very severe. And I was going to the doctor's office, I think once a week. And I have this running joke because I still see the same retina specialist that diagnosed me 16 years ago. And, I knew all the office staff, I knew all the people that worked in the building. And so it was a weekly event for me. Every Friday I would go to the doctor. Hey, Terry, it became a point where I really couldn't do much else because of the scheduling conflicts. I had to go to the doctor every single week. And they were very intense about what my treatments looked like. It was laser, the injections, surgery. So they attacked it pretty aggressively head on. And, thank goodness they were able to preserve my vision.
Yeah. Well, thank you so much, Candace, for sharing all of that. I see we're also getting a lot of written comments, so we just want to pivot here to check in. Robert, what are we seeing?
Yeah, thanks, James. So we get from Keys in Michigan. I've lived on a quarterly schedule of intravitreal anti-VEGF injections, plus in-clinic OCT and fundus photography. Over the years, treatment has evolved from scatter laser to focal laser to vitrectomy, today's anti-VEGF era. Each step has been an improvement, and I'm deeply grateful. And from Dawn in the UK living with type 2, the learning curve has been rapid and scary. Injections in the left eye and a lot of lasers in both. NHS, that's the National Health Service, limitations mean I can't have injections in my right eye. The early days were very dark, both in vision and in fear. And then I guess one more, perhaps, from Susan in Florida, who has a loved one with type 1. My niece went blind after enduring the shots in her eyes. She missed seeing her son's face and her husband's as well. She didn't get to see this big, beautiful world.
Well, thank you for everyone who's been writing in with comments. Know that we are receiving more than we can read but out loud today, but that we are capturing them and they will be included in the Voice of the Patient summary report. I do want to expand the topic a little bit. We've been hearing about some of the things that have been helpful, and of course we want to continue to hear that. But we've also started to hear about some of the trade-offs and downsides of treatments, and so we have a polling question on that topic. So if you can go ahead and open up that polling webpage. If you had it open from earlier, if you closed it out, you can just click on the link under the player or type in pollev.com/DRD PFDD. So here we want to know what are the biggest drawbacks of your current treatment or management approaches, and you can select up to the 3 greatest drawbacks that you or your loved one experience. The options here are A, not very effective at treating the target symptoms, B, the treatments are not preventative, C, it only treats some but not all of the symptoms of DRD. D, it does not restore lost vision. E, it does not stop or slow disease progression. F, the high cost or copay, it's not covered by insurance. G, a limited availability or accessibility. H, the side effects. I, the route of administration, for example, injection. J, it requires too much effort and or time commitment. Or K, some other thing that you view as a biggest drawback of your current treatment and management approaches that represent a top 3 approach. And of course, you can select L if this is not applicable because you or your loved one are not using anything to try to treat or prevent vision loss as a result of DRD.
And I just want to pick up on choice E, does not stop or slow disease progression, and mention that the current gold standards of treatment both treat what was called this morning the neovascularization, the abnormal blood vessels that develop as a result of diabetes effect on the eye and the retina. But what they don't treat is the underlying neurodegenerative disorder, the disorder of the nerves that are also associated with diabetes. So there is slow progression in background, even if we can stop the progression of the vascular disease.
Thank you. So just to report out here what we're hearing from the audience as final responses are trickling in. Looks like some of the top biggest drawbacks are the side effects, the route of administration, and the time, effort and time commitment to keep up with current treatment regimens. After those 3, it looks like the fact that the treatments do not restore lost vision, and as well as the high cost copay not covered by insurance being reported. But again, we're seeing here every single one of these drawbacks is being reported by some number of people, as being a top 3 greatest impact for them. And consistent through our polling, some number of people are currently not using anything. So whichever of these you selected, we really want to hear about these different drawbacks within the context of your treatment journey. So I'd like to get back to our Zoom panel here to kick off this discussion. Nate, maybe we can start with you here. Broad range of different treatment approaches. Any particular treatment experience you'd like to share, whether it's been helpful or not, any key downsides that you have experienced?
So my name is Nate. Thank you for having me. I'm from Philadelphia. I've been living with type 1 diabetes almost 30 years now. And I've been dealing with DRD for 9 years. I lost full vision in my left eye 9 years ago. And as of December, just had surgery on my right eye to make sure that continues to stay stable. My whole experience, it's been keeping my right eye stable because we knew that vision wasn't going to be restored in my left eye. And it was going great. When we did the laser, I was going in about every 3 months. I feel like very similar to Candace, like they began to know my name. They know who I'm seeing. They know why I'm here. And it was going great. And then all of a sudden, like one day it just flipped from my right eye earlier last year. And then we went from, laser to injections and it just wasn't improving. And then I ended up having the vitrectomy in December. So in terms of just treatment and just, drawback is just like, we were doing everything right. I was doing everything right, keeping my diabetes in check. And, what happened? Why wasn't this, we were doing all these things for preventable, to make DRD not happen, or spread to my right eye, like what went wrong. I think that's kind of my drawback with it all.
Sure.
And would you say no, this is really, really good. I want to dig in more and hear more about this. Would you say that drawback, the kind of doing everything right, doing everything at your disposal, yet progression happens, do you feel that, based off of what you were doing at different points in your progression, is that something that you've experienced at each point, like even prior to experiencing vision loss, and then through, you kind of talked about with your right eye, there was kind of that switch that was flipped on, or is there really, kind of particular periods that you're alluding to when you say that?
I think it's just this particular period. I was doing everything that my doctor was telling me. After I lost my left eye, I think Grace had mentioned it. Like the focus was my right. My diabetes, I have in a very tight control to the point where even my endos could loosen up a little bit. But when you're down 50%, you only have 50% left.
Yeah.
So it was, I think kind of going, I think Luke had mentioned it too, it was like what did I do wrong? Like what that mental toll, and it's like, what does the future look like? For me, thankfully, what happened in my right eye was reversible, and it's back to being stable with eye drops right now. But yeah, I know it's constantly on my mind. I was like, I'm almost eager to get back to my eye doctors. Like, how are things going?
Right.
And what can we continue to do? So this was a scary almost what if.
Yeah, sure. And Nate, are there aspects of vision loss that, as you've experienced it, that have been able to be kept more stable versus others? We learned this morning about there's so many different aspects of vision loss. Kind of what does that look like for you?
I'm trying to think. I mean, seeing was kind of always my goal. I mean, that's the goal for everyone. I just wanted to, whatever we could do to keep my independence, I think was my goal. Whether it was losing some pieces of the vision, can I still live alone? Can I still, drive? I work in digital marketing, so can I still go to my job?
Yeah.
I think those were all things that, no matter how this was going to turn out, like what level of independence can I still have from it? And thankfully, we were able to keep all of the vision. My right eye is we're about 2 months in post-surgery, so it's still a little unstable, but it is on track to being back to stable.
Wow, good. Thank you so much, Nate, for sharing that and letting me explore that a bit more with you. Jason, want to make sure we bring you into this conversation. Again, we're exploring any experiences with current treatments in a very broad sense, and in particular, any kind of key downsides or trade-offs. What comes to mind for you?
Yeah, so good afternoon, everyone. My name is Jason. I'm from Salt Lake City, Utah. So I've had type 1 diabetes for 35 years. And pretty recently, I'd say in the last 5 years, I was diagnosed with DRD in both of my eyes. However, I was pretty fortunate because we caught it very early. So I have not experienced any, noticeable vision loss since diagnoses. However, I have been getting the anti-VEGF and then EYLEA injections every 12 to 14 weeks for the last 5 years. And it's for me, like one of the biggest things is it's just kind of daunting, right? It's like I would do anything to keep my eye from my vision. So I will do the injections, but do I have to do every 14 weeks for the rest of my life? Go in and take a whole day off of work and find a ride, find someone to drive me in. So it's more or less kind of the daunting aspect of it is like, but I will certainly do whatever I can to prevent any loss of eyesight for sure.
Yeah, and Jason, just to contextualize where you're at, you mentioned that you have not had any noticeable vision loss, since diagnosis. Was there some initial vision loss that you had experienced, initially, and it's been stable since then, or can you just kind of help us understand your DRD journey a little?
Yeah, I go into that a little bit. So yeah, I just went in to get a new prescription of contact lenses, and the optometrist just was doing the scan on my retina and just saw some abnormalities, and then referred me to an ophthalmologist who really started to look into those. So like I said, I think I'm very, very fortunate to. There was no sudden loss of vision or any changes in my vision that really spurred my diagnoses. I caught it, pretty early and didn't have to go through all of those things. But yeah, and then, just it's kind of funny because I had no vision loss, but then after you get the injections, you have blurry vision for the rest of the day. You're photosensitive. You get floaters, and then recently I had a scratched cornea after an injection, which is, I don't know, I'm sure a lot of you have experienced that, but that was just horrific pain for 12 hours. But so yeah, the injections have caused probably more of a vision loss than, the disease itself for me at this point. So yeah, just kind of a different perspective than a lot of other people, but yeah, I do feel fortunate.
And some of those, post-injection, side effects that you're experiencing, impacts on vision, how do you, think about that? You're doing this to help preserve your vision, and then it's, causing vision-related, side effects. Is that, kind of just a side effect, a trade-off that you are, okay with, given the what you're hoping to get out of the therapy? How do you weigh that, when you're, considering maybe even the frequency at which you would be willing to get those?
Yeah, absolutely. So one of my favorite endocrinologists I've ever had when I was a kid told me once, if you get kidney disease, you can get a new kidney. If you have, foot problems, get on top of it. But, but what you don't want to do is lose your eyesight, right? You can't get new eyeballs. So that's one thing that he really stuck in me when I was a kid. And so it's so alarming, like when you first learn, like, hey, we see some abnormalities in your eye. Yeah, I think that from my perspective, I was like, okay, yeah, I have to do whatever I can to keep my vision, because it's so important. Like I think, once you don't want to take it for granted, your eyesight. So for me, yeah, I literally would move heaven and earth to to do whatever I can to make sure it does not get worse or progress further.
Yes. Well, thank you so much, Jason. I see we have a couple of phone callers I want to bring into this conversation as well. First, we have Nina from Sarasota, Florida, who's living with type 1 diabetes and DRD, and wants to share some of her treatment experiences. So, Nina, I'd like to welcome you to the program. Are you with us?
Hi, Nina.
Yes, thank you so much for organizing this meeting, and I'm happy to share my experience with treatments with having DRD. I have had laser, anti-VEGF, and vitrectomy. When I was first diagnosed, and when eventually I got a vitreous hemorrhage in my right eye, I got the typical treatment of laser. At the time, they said I should have gotten laser actually probably 2 years before.
Okay.
Was the comment that my retina specialist gave me, and unfortunately, after I got laser, as these bad blood vessels, they call them, were pulling back, they caused more bleeds. And I was unfortunately told that I was not a candidate for anti-VEGF injections because I don't know how many cases are out there, but my vitreous was actually pulling on my retina.
Right. Okay.
And so they were afraid that this would actually cause, retinal tear, retinal detachment. And so I was never given that option. And so I actually went to another retina specialist who's one of the top in the country, and he was willing to take the chance of, injecting me. But it was too late by that point. I had gotten so many bleeds within sometimes 2 to 3 weeks that my right eye was completely blind by the time I was given the option of anti-VEGF injections. Okay. And eventually that led to having to do vitrectomy because there was no other options left. I was trying to push that off for some time, obviously not wanting surgery. But it was obviously very terrifying. I never actually thought that I would be like, please give me an injection in my eyeball, but that's exactly what ended up happening. I was begging for it, but didn't have that option.
Right. And so, Nina, with kind of understanding those difficulties and, where you are today, as you're kind of, can you maybe just tell us a little bit about your treatment kind of approach right now? Is there anything that, you're, able to do or currently doing to try to, kind of maintain where you're at today?
Yeah, definitely. So it's been over a year since I've gotten my vitrectomy in the right eye. I was getting injections post-surgery about every 6 weeks. And I was recently told that I don't have to, so I can wait. It's really completely my option if I want to or not, because the progression has stopped in both of my eyes. However, I will tell you that, unfortunately, my vision has been somewhat compromised in my right eye. I still have flashes, floaters. So that's still happening in my right eye, and obviously floaters in my left eye too, but that's my good eye. So I kind of compare it to sometimes you see these pictures of Earth and the number of satellites that are around it. That's how it looks like. Like, I just have so many things in my eyes, so many things floating in my eyes. So that's another thing that I've been left with. But luckily, I don't have to get as many injections, or at this point, it's optional.
Sure. Well, thank you so much, Nina, for being willing to share that and some of your treatment experiences in the past and where you are today. I want to go to another caller. We have Brad from Michigan, who's living with type 2 diabetes and DRD, wants to weigh in on some treatment experiences. So, Brad, I would like to welcome you to the program. Are you with us?
Hey, Brad.
Thank you very much. It's great to be with you all today.
Thank you.
I'm happy to share my experience. You should know, first of all, that I'm a 71-year-old retiree who's been treated for diabetes for at least 15 years, perhaps longer than that.
Yes.
And for a significant amount of that time, I've been treated by one of 2 different ophthalmologists in my hometown of Ann Arbor.
Okay.
And I've been grateful for their care, for their knowledge, and in their personal investment as me as a patient and a friend in both cases. I value that relationship. My eyesight has been treated, my DRD has been treated initially by Avastin and then by Eylea HD, and I also early on had laser surgery, which helped with what it was supposed to help with, but it also cost me peripheral vision.
Sure.
And my particular concern right now has to do with the gulf that exists between how my eyes are assessed and judged in a clinical setting and how they operate once I'm out in real world situations. So like most DRD patients, when I go in, I'm asked to read an eye chart. Various exams are done of my eyes. I have a brief consultation with my physician, and then I go in for an injection.
Okay.
And photography is often done too, and the doctor will show me the photographs and usually tell me that the Eylea HD is working really well, and that there isn't much damage that he can see. When I go home, I find that I'm largely unable to read, unable to watch television, unable to drive a car safely, unable to discern changing traffic lights, unable to read recipe cards, unable to read mail that comes. Sometimes I have to hold a computer screen right up by my face in order to read that, even within large type. So my frustration is this distance that seemingly exists between the way that my eyes operate in the real world and how they are assessed and treated in a clinical setting. I understand that my doctors are both following precedent in their field, and I'm not second-guessing the treatment, but I'm saying, how can my eyes appear to be one way in a clinical setting and yet very different when I'm back engaged in real life?
Yeah, and Brad, that's a very important observation, and kind of this discordance between clinics assessments and your lived experience at home and out in the real world. Do you find that it's because you're kind of describing the difference in the assessment itself? Does that also extend to how you would say kind of the benefits of treatments are overestimated in the clinic relative to getting some benefit in the home and out in the real world? Can you just kind of speak to if there's any difference there as well?
So I definitely wouldn't want to go without the treatment.
Right.
And I know when my eyes are due for a treatment, but I'm suggesting that this isn't all that there is to it. That my ability to see is judged on the basis of some photos that are taken in the clinic and my ability to read an eye chart. And all that is well and good, but there are many other ways that one could assess in real-life settings one's ability to use the eyes and to see, and that those aren't being taken into the current way that one understands and assesses the health of one's retinas.
Yes.
And James, let me just jump in on that, because it was mentioned by Dr. Gardner and by Dr. Sun this morning, the importance of including functional variables, measures of visual function, into the usual exam, because what we're doing now with our current gold standard is we're treating the neovascularization, as I said before, so you get prettier pictures of the retina, but that does not tell you how the retina is functioning behind those prettier pictures. And I think Brad brings that forward, and it's really a critical point to be made, especially as we look forward towards what's the next tier of new therapeutics that can help preserve the function of the retina so that we can preserve vision.
That's right. So Brad, thank you so much for calling in and help highlighting, in your, experience what that gap, that discordance is. I want to, before we move off this topic, just check in with our Zoom panel, see if there's, with a little wave of a hand, any treatment that maybe we haven't really talked much about yet, that you have experience with, if there's anything that you'd like to share, maybe that is a little less common, hasn't come up yet as part of this current treatments discussion. All right, well, I know we've been getting, oh yes, sure, Grace.
One thing I just wanted to say, and I do think it technically falls under the treatment umbrella, and Jason and Lou, several people have touched on this, but I do think one of the things with DRD and the mental burden is you're told a lot that if you get a complication from type 1, that it's your fault. It's something you have done. And I think early on in T1D, your kind of complications are used as a scare tactic and, oh, don't do that, or you'll lose your vision, or you'll lose a foot or a kidney or something like that. And I think is kind of and we've all been walking this road for quite some time. I just don't think that's productive for either the patient, or anyone else really. And just kind of, I'd love to see as we look towards the future, kind of that language change and say, hey, this is a possibility, but there are options out there, and kind of making it less of a, you failed as a diabetic if you experience these complications. So I, know that technically wasn't your question, but I just wanted to squeeze that in there before we wrapped up.
No, it is, and certainly that kind of broader perspective is within the scope of treatments, and strategies, and hearing that kind of important, really it is a downside. We've heard so much about all of the burden of bearing the uncertainty of all of this, and then having that kind of almost blame placed on you on top of it all, is important to hear about. But Robert, I'm going to turn to you. What are we seeing in terms of written comments on this?
Yeah, and from the standpoint of other therapies that might be out there, this from Dawn, who's living with type 2 in the UK. She said in January 2025, she was advised of her type 2 diabetes, ordered a CGM, a continuous glucose monitor, and learned my HbA1c was 19. Went on metformin, changed my diet, and now I'm at 5.1. No one ever said there was a risk of lowering it that quickly, but blurred vision, maybe take a standard eye test and diagnose with stage 3 proliferative retinopathy in the left eye and stage 2 in the right, end quote. And that is something that's been observed with the broad use of the GLP-1 agonist, which is if you have long-standing diabetes and have a very high A1C at baseline and it drops too rapidly, you are in fact at risk of progression, of your diabetic retinal disease. And that's just coming to the fore in people's understanding as these drugs are more broadly used. I mean, other comments we have from Adriana in Falls Church. She says the most significant downside to current available treatments, surgery, laser, injections, is that they are not only destructive but also traumatizing. None of them are helping to regain vision loss from diabetic retinal disease. They're all barbaric, she says. The eye injections that I've been receiving every 1 to 4 months over the last 12 years have prevented me from being able to get pregnant. DRD has not only chipped away at my independence, but it stole my and my husband's dream of expanding our family.
Yeah, wow. So profound. And again, thank you for everyone who's been writing in. Please continue to keep those comments coming. So I do want to make sure that with the remaining time we have, we shift gears a little bit and look towards the future. And so we're going to start off here with a polling question. This will be our last polling question of the day. So please go to that webpage if you had it up. You can click that link under the player. You can open up a browser and type www.pollev.com/DRD-PFDD. So while we all want a complete cure or a complete, something that would completely prevent the onset of DRD, here we want to know what specific things would you look for in an ideal treatment for vision loss from diabetes. This is whether you're at risk or currently experiencing vision loss. You can select the top 3 things that you're most looking for in that future treatment. The options here are A, to slow or stop disease progression, B, preventative interventions before vision loss occurs, C, preservation of functional vision, not just visual acuity, D, more durable and long-lasting treatment benefit, E, reduced need for invasive procedures, F, reduce monitoring and emergency interventions, G, improve one or more aspects of vision, or H, improve specific activities of daily functioning. And finally, I, some other specific thing you would look for in an ideal treatment for vision loss as a result of diabetes that represents a top 3 greatest thing that you're looking for.
Yeah. And I would just say, looking at this, it's interesting because although a lot of pharmaceutical companies, have pipelines which are will take a while for their new drugs to get to market. The drugs that are coming to market now often are more durable or longer-lasting versions of anti-VEGF treatment. So it's interesting to see from the perspective of patients that's not necessarily a plus-up. As compared to, other sorts of interventions that are more preventive, preservation of vision, can preserve function and so forth. So that's an interesting observation.
Yeah, we're seeing that preservation of function. Functional vision is a top treatment goal, followed closely by preventative interventions before vision loss, and then something that would slow or stop disease progression right up there as well. We do see kind of then after that a little bit of a drop off, the more durable and longer lasting treatments and less invasive procedures as a top treatment goal, as well as some other things. We'd love to hear from you about what those other things are, as well as some number of people reporting that a top treatment goal would be seeing improvements in their vision and improvements in specific activities. No one noting reducing monitoring and emergency interventions as a top treatment goal. So thank you for doing all of these polling questions throughout the day. As always, they're helpful as we now launch into the discussion. And I would like to now come to our panel and do a little bit of a round robin here with our Zoom panel, to have you each answer this very important question. And I know it's a difficult one to just narrow down kind of the top thing that you would like to see. Candace, maybe we'll start with you and go around here. What's at the top of your list for that, future treatment that might come along?
Definitely improvements in daily life. I think for me at this point, because I've been stable for so long, it's really a fear of mine that stability could slip through my hands. And so, being able to keep up with the things that are important to me now, which are my family and the work that I'm doing. So thank you. That was a great question.
Thanks, Candace.
Yeah, and Candace, just to follow up on that, is there some amount of slipping, as you called it, that you're kind of particularly worried about? What would that be that might lead to reaching a place where you aren't able to keep up with your family and do those things that are important to you?
Yeah, I think every time I visit the eye doctors and have a seat in that chair, there's always this feeling in the back of my head, like this could be the time where my stability has slipped, and so I think just maybe some sort of a daily something that maybe we could do at home to help meet a marker or something. I know that the eye drops for me are very reassuring. It's like my daily dose of my ability to keep my stability and my independence. And so it would be something along those lines, James.
Yeah. Well, thank you so much, Candace. Coming around here, again, we'll ask each of you to weigh in on this important topic. Jason, what is a top treatment goal that you'd like to see in a next future treatment?
Yeah, absolutely. So as I kind of alluded to, the treatments for me have been fairly effective, at least according to my doctor, where I've not had any disease progression so far. But yeah, just a longer lasting. So having to get the injections every 12 to 14 weeks, it's just kind of a big burden on everyone's life. And something that's, if even possible, something less invasive, right? Where you're not having to get a couple different numbing injection and then the disinfecting and all that stuff. If there would be a better route of administration or anything along those lines that make it easier to get the medication, it would be wonderful.
Thanks, Jason.
Sure. And Jason, is there some amount of I guess the less invasive part is a little easier to understand, but in terms of making it less frequent, is there some amount of kind of increased time between doses that would be valuable to you?
Any increase in time, any improvements on not having to go in so often, where you're going in 4 times a year, even if it was just once or twice or something, like just improvements in that area I think would help me tremendously, I think.
Sure. Wow. Well, thank you, Jason. Nate, coming around to you, short of that complete cure, what's a top treatment goal for you?
Chose preventative intervention before loss occurs. Like I said in my story, I was doing those things and it still happened. So, what can we do to improve that? So, if we're doing all these preventative things, it's not going to happen. I think that's my main focus.
Yeah, and Nate, if something were to come along and it could delay, the onset of vision loss, maybe if it didn't even, couldn't fully prevent it, that might be more like that cure. Is a delay in onset or meaningful, or is it more about, the severity of the onset, or both?
I think it's kind of a combination of both. I want to be able to see my own terms as long as I can.
Yeah.
So if, that gives me 30 more years, that's a better option than not having those 3 years now.
Right. Yeah. Thank you so much, Nate. Luke, coming to you, what would you like to see in the next future treatment?
Yeah, again, I'm not purposely affected by DRD or any eyesight issues as of yet, but what I would love to see, especially out of the endocrinology, community, is a more collaborative effort between the different doctors that touch our lives, because it's not just an endocrinologist, it's an eye specialist, it's cardiologists. There's so many different touch points to this disease, and a more collaborative effort or a way to make that happen between doctors, I think is important when you're looking at future care and preventative care.
Absolutely. Yeah. Thank you, Luke. And Grace, last but not least here, want to make sure we get your input on this important question of future treatments.
Yeah, I think my answer would definitely echo Candace's answer. I would love to know that, because I've kind of adapted to where we're at now vision-wise, and I can be independent and all that good stuff. But again, every time my blood sugar's high, I'm like, oh no, if I'm sick and my blood sugar's high, which you can't control getting sick, I think, oh my God, all I can think about is, oh my gosh, damage is being done to my eyes and I can't do anything about it. And so just kind of that anxiety, which isn't good for blood sugar either, of just that constant worry, like, okay, things are fine now, but my world could get flipped upside down. It's like Russian roulette almost. You just don't know. So I'd say more, assuredness that the treatments are working and that progression has been either slowed or stopped entirely is what I'd like to see in the future.
Yeah. And Grace, how would you define, what would count as like, slow progression versus what is a little too much, it would, kind of be outside of what you would be looking for, in a treatment?
Yeah, I'd say, I'm not greedy. I would even settle for like a definite timeline. Like you won't see any, with X treatment, you won't see any additional vision changes between the next 7 and 10 years.
Mm-hmm, right.
Again, I think time is the most valuable part of this, as kind of a collective thing, is just knowing more predictability with it would be nice, I think, is my TLDR of it all, is just kind of being able to predict what's going to happen in the future a little bit better would be great.
Oh, that's super helpful. And I just want to thank all of our Zoom panelists here today for all of your really important insights and experiences that you've shared with us. It's been really helpful as part of this discussion here, as I now want to get to some callers on this topic. So I just want to say thank you. We do have some callers. I'd like to have share some of their views on future treatments. We have Amy from Michigan, who's a caregiver to her daughters who have type 1 diabetes. Amy, I'd like to welcome you to the program on this topic of future treatments and ask, are you with us?
Yes, I am. Thank you for having me. As you had said, I'm Amy from Michigan, and I'm a mom of 2 daughters who were diagnosed with type 1 diabetes. And it's something important to know is how we first came into this experience of that diagnosis. Our first daughter was diagnosed in a very urgent state, and she ended up having typical DKA symptoms at 3 years old, which landed us in a week-long stay at the PICU of the Children's Hospital. Our second daughter, it was a very different experience. we were actually able to catch it really, really early. And when this happened, it was at the time where not all the markers and stages for type 1 diabetes had been identified. So she was diagnosed in December, but actually didn't need insulin until about July. Okay. And even when she started insulin, she only took tiny little bits, not even a basal rate, only enough to cover her meals.
Okay.
So I share this because it's so important in the sense that here we are now. We couldn't find a cure. We couldn't delay her onset of type 1 because Tzield hadn't even come to market. There were no stages identified for pre-diabetes in type 1. And with eye disease, it's currently in the same state. We know that it's a possibility, but there's nothing that we can do to stop it. There's no medications that my girls can take to delay onset or to keep themselves from having this. It's just something that could happen, and it's a big concern and worry. So I think as we go through this, to get there, we're going to need to have a data collaborative where we start to better understand those early stages and identify them and work towards treatments that address them before they become a big concern. So it's really my big push is just to get out there and share this information. Someone had mentioned collaboration amongst all the providers. If we could have that collaboration and symptoms started to go into a database and we could talk about that, we might have those markers to better identify before this even becomes a problem and stop the onset of what could be DRD.
Yeah, and Amy, and part of trying to understand, that and get to that point, one of the things that I want to hear from you is, if something were to come along, let's say we're successful in doing that and there a treatment, or maybe it's a research trial were to come along, that, it would be for that stage where your daughters are at, what would be important to you in knowing, about that treatment or the, possible, kind of approach that treatment is trying to achieve, to decide whether, you and they would want to enroll in that study or try that new treatment?
I think treatments and trials are absolutely wonderful. One of the downsides is right now they're hard to access, so they're not always well advertised. So I think getting the word out of what trials are available, to share that information, to publish it on social media, to make sure that it's on LinkedIn, that, eye specialists have that information and they're not afraid or hesitant to approach their patients about it is a big first step. And then the second piece is once we have that information, it's the accessibility. So having those trials in areas where patients are and can get to, not just at one center in the United States, but at multiple centers and locations, to make it so that patients can actually be a part of those trials is really, really important. And not to obscure people from the trial that should otherwise qualify. I think sometimes we narrow down the scope of who can be in that trial so that potentially good candidates are excluded for whatever reason, whether it's age or maybe it's the amount of time that they've had diabetes. I think we have to look bigger than that and think about this from a larger population perspective, knowing that this is something that affects so many people. Opening that scope up of who could be in a trial would be a really important next step.
Yeah. Well, Amy, thank you so much for calling in and weighing in on this, important perspective of preventative treatments and kind of what was important to you as a mom, a caregiver, and what that could look like. One more caller here I want to get to is Chris from Utah, who's living with type 1 diabetes, does not yet have DRD, but wants to share his treatment, what he'd like to see in future treatments. So Chris, I'd like to welcome you to the program. Are you with us?
Thank you for allowing me to share my perspective, and thank you to the Mary Lee Tyler Moore Vision Initiative for hosting this conversation and for all of the FDA and drug and device developers for taking their time to listen. I'm a type 1 diabetic of 37 years and have been fortunate enough to not yet have diabetic retinal disease. And many of my comments echo previous panels and callers and really reinforce their asks. I'm at a high risk of developing diabetic retinal disease, but my individual risk is not clear by all all measures, I should probably have this, given Dr. Sun's earlier presentation. So I end up living with the expectation of vision loss and have had that expectation for decades. And so I'm simply waiting for that to occur. And fortunately, it hasn't. But in the meantime, there's really not much I can currently do to prevent the onset of diabetic retinal disease outside of the measures I already take to properly handle my type 1 diabetes as best I can and live a healthy lifestyle. And so this really leads me to two requests of academia, industry, and the FDA. The first is pretty specific, and the second much more broad.
Okay.
And that is, I would love a risk score that measures my personal 5-year, 10-year, and or 15-year risk of developing diabetic retinal disease that's aggregated from all of the best and currently available prognostic indicators. I would really love to know when and how I can intervene.
Yeah.
And in the absence of being able to intervene, which really doesn't exist at this moment, to echo what Grace was saying, I can plan my life, plan my future, if I know that I'm at high risk of losing my vision in 5 years or 10 years or 15 years or whatever that time horizon might be, right?
Okay.
And then with that, with knowing my likelihood of developing disease, I would love a preventative intervention, some way to stop the development of vision loss and prevent it from leading to those traumatic treatments that have been discussed at length today.
Right. Yeah. And Chris, for you, in terms of a preventative, certainly if we could, absolutely stop the onset, that would be important and a huge benefit. Would there be benefits to something that would, slow the onset or reduce the severity of the onset for you as you're thinking about your kind of situation?
Yeah.
Absolutely. Yeah. The more time that I can have my vision, the better.
Yeah.
And the better the state of and the quality of that vision, I'm happy to have that.
Absolutely.
Yeah. Well, thank you so much, Chris, also for chiming in here on this really important final question of the day. We'll give the final word to those of you who have been writing in on this topic of future treatments. Robert.
Yeah, thanks, James. So the two strong themes that are coming through in the contributed comments is what we've heard already from folks, that we need a focus on prevention and less invasive sorts of treatments. So one of the comments from Monica in Boston says, I would be very interested in opportunities for prevention, either through a medication or even behavioral changes to help reduce my risk of DRD. An ideal treatment would be one that addresses symptoms in their entirety, prevents advancing the disease, and allows for improvement or resolution of DRD. Even further, an ideal treatment would be less invasive than current options. And there's another insight that I thought I would bring forward in this. Is from Keys in Michigan. Now, Keys has type 1 diabetes. He has the diabetic retinal disease himself, but he also has 2 young daughters with type 1 diabetes. And he reminds us that an ideal treatment must deliver pediatric appropriate dosing, delivery methods, and monitoring strategies from the earliest possible age, so my daughters never have to feel the terror I felt when the world started to fade.
Wow, incredible. I just now, as we're wrapping up the part of today, where we're hearing your voices, the community's voices, people living with diabetes and their care partners. I mean, this just has been an incredible day. We set out to try to have a better understanding of what it is that you live with, what you go through, how you navigate this complex, and challenging, treatment landscape. And you really have done that as your moderator. From the bottom of my heart, I want to thank you for pulling back the curtain of what it is to be at risk for and live with DRD here. Just the anxiety of the uncertainty, no matter where you are in your journey, has just been so profound as I've listened to each of your stories. I can't, say how many times I heard today people, saying, I doing everything right, and yet I still, am experiencing this disease, or I just don't even know if that's going to be good enough. I can't imagine how hard it is, to share those, anxieties, with the world. But you did that today. You all really stepped up, and it's been my absolute pleasure to be a part of this with you. So just again, I want to thank you as the moderator. At this point, it's my pleasure to turn it over to our speaker, who's going to provide summary remarks. It's truly an impossible task to try to summarize a meeting like this, but fortunately, we're in good hands with my friend and colleague, Sarah Wicks. Sarah, has dedicated her career to bringing together, diverse stakeholders across industry, regulators, patient communities to help drive and advance therapies for patients in need. And she has been a critical part in helping plan and organize today's meeting. So without further ado, I'll turn it over to Sarah to give us a summary. Sarah?
Thank you, James. The meeting opened with remarks from Dr. Robert Levine, founder and CEO of the Mary Tyler Moore Vision Initiative. Dr. Levine shared his personal connection to diabetic retinal disease, or DRD, as the husband and care partner of Mary Tyler Moore, whose life and remarkable career were later shaped by vision loss from diabetes. Dr. William Boyd, Director of the Division of Ophthalmology at FDA, shared that this meeting will give the agency direct insight into what it's like to live with DRD, which will inform FDA's thinking throughout the drug development and review, shaping what outcomes are prioritized and identifying what benefits are meaningful and what risks are acceptable. We then heard from Dr. Jennifer Sun, professor of ophthalmology and surgery at Harvard, who shared that DRD is a progressive complication of diabetes, affecting both the blood vessels and neural tissue of the retina, often beginning without symptoms and advancing to proliferative disease, macular edema, retinal detachment, and vision loss. Of the more than 20 million people in the United States living with diabetes, over 9 million have DRD. In the morning, we heard from members of the diabetes community who so bravely shared what it means to live with diabetes-related vision loss, or the fear of it. The most significant symptoms described were not always dramatic hemorrhages, but the gradual erosion of visual clarity and confidence. Reduced visual acuity was repeatedly identified as life-altering. One participant described the decaying of vision to the point that reading signs or recognizing people from a distance has become difficult. Others described words swimming on a screen, faces failing to sharpen, and the need to reread sentences multiple times because their eyes refuse to cooperate. Difficulty seeing in low light and at night emerged as one of the most limiting symptoms. Participants described rainy nights, glare from headlights, dim restaurants, and bright marble steps appearing flat and depthless. One explained that she tests each stair with her foot, always holding a handrail, sometimes a flashlight, aware of the risk of falling. Others have already stopped driving at night altogether. Loss of contrast sensitivity and peripheral awareness was described not only as inconvenient, but as exhausting, requiring constant vigilance and mental calculation. Sudden visual events were also shared. Some described floaters mistaken for insects, flashes of light like going into hyperdrive in Star Wars, vision appearing to fill with water or blood, or shadows that trigger immediate panic. These episodes are frightening, but what lingers most is the uncertainty afterward, never knowing when it might happen again. The emotional impact was equally significant. Anxiety was pervasive. One participant described living in constant panic after her first hemorrhage, with every new floater or shadow triggering fear. Others shared that ophthalmology appointments bring weeks of anticipatory anxiety, bracing for news that progression has occurred without noticeable symptoms. Some cope by trying not to think about future complications at all, pushing the possibility of vision loss aside. Yet they cannot truly ignore it because they must continue to monitor their glucose, adjust insulin, and manage every detail of their life to reduce the risk of DRD. Depression and shame also surfaced. Some spoke about internalizing stigma, feeling that complications reflect personal failure despite diligent diabetes management. For those who have not yet experienced vision-threatening disease, fear remains constant. Living with diabetes means knowing that even careful glucose control does not guarantee protection. The possibility of vision loss always looms quietly in the background. As the conversation turned to daily life, the cumulative impact of these symptoms became clear. Driving was repeatedly identified as one of the most painful losses or anticipated losses. Night driving is often the first activity to go, with many participants sharing that they have already stopped driving after dark. Others fear losing driving privileges entirely. The loss of driving was described not simply as an inconvenience, but as the loss of independence, spontaneity, and even identity. Work is also affected. Participants describe difficulty with prolonged screen use, enlarging fonts, switching to dark mode, and pushing through eye strain and dryness just to maintain employment. Many fear losing their jobs if vision worsens further. Even routine activities require adaptation. Reading small print, grocery shopping, navigating crowds, painting a child's nails, walking downstairs, or moving through dimly lit spaces demand focus and caution. One participant described constantly scanning and anticipating hazards rather than moving instinctively. Another shared that she feels her world becoming smaller, withdrawing from social settings she once enjoyed. Fear about the future was universal. Several spoke about doing everything they have been told to do, monitoring carefully, maintaining glucose control, attending appointments, and still living with the knowledge that DRD can develop despite their efforts. Many fear worsening impairment and blindness. Others fear missing milestones, celebrations, or the faces of loved ones, and about how vision loss would reshape family dynamics. The unpredictability of progression and the disconnect between how vision feels and what scans may reveal leaves many living in a state of quiet vigilance. Loss of independence and autonomy was described as equally frightening. Participants worried about becoming dependent on spouses or parents, and several described how vision loss shifts responsibilities onto partners who must take over driving, childcare, and household management. Others worried about how blindness would change family dynamics and financial stability. For young people living with diabetes, these fears carry additional weight for them and their parents, worrying not only about what may be lost today, but how vision loss could reshape their careers, relationships, and future still unfolding. Overall, the morning underscored that DRD is not simply about changes on a retinal scan. It is about diminished clarity in low light, flashes that disorient, and living with constant uncertainty. It is about grieving independence in small increments and fearing how much vision will remain tomorrow. In the afternoon, we turned the discussion to treatments for DRD, what has worked, where treatments fall short, and what patients hope to see in the future. We heard from Dr. Thomas Gardner, professor of ophthalmology at the Kellogg Eye Center at the University of Michigan, who explained that treatment often begins with controlling diabetes and that ocular therapies include intravitreal injections, laser treatment, and intraocular anti-inflammatory medications. While these approaches can stabilize vision for many, they often require repeated interventions and ongoing monitoring. Patients and caregivers echoed that current treatments have preserved and helped to maintain vision. Several described structured schedules of anti-VEGF injections, often every 8 to 12 weeks. Some have transitioned through scatter laser, focal laser, and vitrectomy to today's anti-VEGF therapies, expressing gratitude that their disease can now be stabilized. Others described switching medication in search of longer durability, noting that vision may improve for a few weeks after injection, but then begin to fade as the medication wears off. Laser therapy was described as both protective and limiting. Some shared that laser and cataract surgery enabled them to continue working, create art, or maintain central vision. Surgical intervention, including vitrectomy, was described by some as life-changing in restoring clarity after bleeding. At the same time, treatment burden is significant and outcomes are not guaranteed. Repeated injections were described as anxiety-provoking. Several participants spoke about their fear of the needle, the need for sedation to manage anxiety, and discomfort when numbing drops wore off. Earlier generation of laser therapies were described by some as destructive, permanently altering peripheral and night vision while protecting central sight. Others described severe headaches, nausea, or intolerance to laser treatments. Several emphasized that while current treatments may stabilize, they may not ultimately restore vision that's been already lost. There were accounts of progression despite intervention, including loved ones who had ultimately lost their sight. One participant shared that after experiencing many recurrent bleeds, they were no longer a candidate for anti-VEGF injections, and their only remaining option was a vitrectomy, a decision that carried both hope and fear. The logistical burden is also substantial. Participants described long drives, missed work days, child care coordination, and days spent effectively offline after these treatments. One described several full days each year where they are unable to work or drive normally while their spouse has to carry the entire household load. For some women, the burden of treatment extends beyond the clinic and has limited their ability to become pregnant and expand their families. At the same time, many participants made clear that when weighing these burdens against the possibility of further vision loss, they are willing to endure frequent injections, side effects, discomfort, and significant time commitments if it means preserving their sight. For many, the trade-off is not between comfort and inconvenience, but between burden and blindness. When asked about future treatments, participants emphasized longer-lasting therapies that are less invasive, such as drops or pills. But even more strongly, they highlighted a major unmet need: treatments available before vision loss begins. Today, most therapies intervene after bleeding, swelling, or structural damage has already occurred. Participants called for preventive options, therapies that could be initiated earlier in the disease course when vision is still intact, to reduce risk rather than react to damage. In addition to rescue procedures used once vision is significantly threatened, participants expressed a desire for interventions earlier in the disease process before meaningful vision changes occur. Prevention, earlier detection, slower progression, and stronger integration of retinal care into diabetes management were recurring themes, particularly for children and young adults who have their futures ahead of them. Several expressed willingness to participate in clinical trials, especially if research could reduce burden, delay progression, or protect vision before irreversible loss. Many expressed being eager to participate in research if only it were more accessible and they could meet eligibility criteria. Overall, the afternoon discussion highlighted meaningful advances in treatment that have preserved sight for many, but also have significant physical, emotional, logistical, and financial burdens. Participants expressed gratitude for progress while urging continued innovation toward therapies that are less invasive, more durable, more preventive, and slow the progression. A theme that echoed throughout the day was that people living with diabetes can do everything right: monitor closely, manage glucose diligently, attend appointments faithfully, and still develop DRD. Participants emphasized the disconnect between how vision is measured in the clinic and how they function in daily life. Reading letters on a chart under controlled conditions does not always capture the ability to read mail at home, distinguish traffic light colors, navigate unfamiliar spaces, or move confidently through the world. Meaningful outcomes must reflect real-world function, not just numbers on a chart. For them, treatment is not about correcting mistakes. It is about protecting sight despite relentless effort. Future therapies must recognize that reality and strive not only to stabilize anatomy, but to preserve independence, dignity, and quality of life. Thank you so much to everyone who shared their story today. And now to close the meeting, we'll go back to Robert in the studio.
Thank you for your thoughtful summary, Sarah. This has been an incredible day and certainly one of the most meaningful of my tenure as founder and CEO of the Mary Tyler Moore Vision Initiative. Today has helped us all better understand diabetic retinal disease, its impact on people living with diabetes and their loved ones, and the need for better treatments for this vision-threatening, joy-stealing, autonomy-robbing disorder. Thank you to the FDA staff who tuned in today. And thank you to Lena Merzog from the FDA's patient-focused drug development staff who graciously guided us through this process and over the many months of planning. Thanks also to Sarah Wicks and James Valentine from Hyman, Phelps, and McNamara, whose assistance in planning and moderating today's meeting has been invaluable. Thank you to the Dudley Digital Works media team for the production planning and all the behind-the-scenes work they have done today. A big thanks again to our sponsors, Boehringer Ingelheim, Regeneron, and Genentech, and to our panelists and discussion starters, and to Latrice Faulkner and Jocelyn Clancy, Dr. Sonnen Gardner, along with the entire Mary Tyler Moore Vision Initiative team. We could not have done this without your support and participation. And finally, a huge thank you goes to you, our entire community of patients and caregivers impacted by diabetes and diabetic retinal disease-related vision loss. Thank you for bravely sharing your experiences and the fears associated with them. This meeting could not have been as powerful without each and every one of you. In the coming weeks, we'll compile all of the information from today, including polling data and written comments, into a Voice of the Patient report, which will be available on the Mary Tyler Moore Vision Initiative website. The form to submit additional comments for the Voice of the Patient report is open for another 30 days. So please consider sharing additional comments. Just go to www.marytylermoore.org and click on the Share Your Comments button. Today's program will be available on demand immediately following this meeting at the same link you are on right now. Lastly, it has been my honor to support this meeting, which I am confident will have lasting impact on the future of diabetic retinal disease research and medical product development. So once again, to the entire community, thank you for making your voices heard today.